Good morning, this is the clerk. This meeting is expected to start at 9:40 a.m. We expect to start in 10 minutes.
Okay, good morning. It's 9:40. Welcome, everyone. We'd like to go ahead and call the Health and Hospital Committee meeting to order at this time. I'm Supervisor Otto, lead chair of this committee, along with Vice Chair Supervisor Margaret Abe-Koga. With both supervisors present, we do have a quorum. First, we move to the public comment for items reserved for members of the public to address the committee on any items not on this agenda. And those who would like to speak regarding items not on the agenda should request to speak at this time by filling out a card. I'm going to ask our clerk, Jess, would you please let us know how many speakers we have this morning?
Thank you. I have one card in chambers and 2 requests online, total of 3.
All right, 3 minutes each, please. Thank you.
Thank you. We'll take our first speaker in chambers, Randall Pham. At the podium.
Good morning. First, I want to thank the administration and the member of the board supervisor for responding to the comments that we had at the last budget meeting. What we hope to do is, at the level of policy, I think we are on the same page. What we need to do is have actionable items so that we can provide you with, and the communities, we're willing to work with you. Community leaders, the physicians, community are willing to work with you to resolve all issues so that we can continue to provide not only continuity of care, but also quality care for the community, especially the non-English speaking community. Thank you.
Thank you.
And we'll move to our Zoom speakers. Our first speaker is Parent. You'll have 3 minutes.
Yes, hello and good morning to all of you. We have a problem here in this county when it comes to child abuse, particularly when it comes to sexual molestation. I think that the person who is promoting this kind of culture is District Attorney Jeff Rosen. He's helping to cover up the sexual abuse of my own kids. And I just recently found out that he used to be he is part of the Wexner Foundation. This is a foundation that was started by Leslie Wexner. And he's been a part of this organization since 2008. And he even continued to be part of this organization after Jeffrey Epstein was arrested for a second time. And I know this sounds like a conspiracy theory, but anybody here can Google DA Jeff Rosen Wexner Foundation. You can go to the foundation's website and see that he's part of it. And just recently, in March of this year, this foundation was sued by 11 sex trafficking victims. And they allege that this foundation organized and financed the sex trafficking. And also, they allege that Jeffrey Epstein was the de facto CFO for this organization. And I just think it's an embarrassment to our county that Jeff Rosen used his official title and helped promote this foundation and participated in their activities. And this organization is just sex trafficking victims. It was just a cover. And we really need to look into this. I mean, anybody can see this lawsuit. You Google Wexner Foundation lawsuit. You'll see all this information. It's publicly available. It's out in the open. And we just reelected this guy. We really need to look into removing him, because it's not just my kids that he's doing this to. There are other parents who are complaining or have complained about the same terrible things that he's done to cover up sexual abuse and silence people who just want their kids protected. Thank you so much for your time.
Our final speaker is Min Tran. We'll open your microphone. You'll have 3 minutes to speak. Min, you'll have to accept the unmute. There we go.
Yes.
There you are.
Thank you. Good evening, good morning, ladies and gentlemen. My name is Ming Tran, and my subject today is urgent request to protect patient-free choice and the community physician networks in the Santa Clara Family Health Plan in the coming years. So we have concerns about the all the facts going on, to deal with the federal healthcare funding massive deficit, and under the Board of Supervisors leadership, the Santa Clara Family Health Plan Board utilizes a single plan policy that raises a lot of problems to the community patients and the community physician, and serious concern to the county healthcare system monopoly as well. So as far as we know that the concerns about the long-term and severe risk to the public health outcomes for several critical outcomes or reasons. Number one, destruction of the continuity of care. And number two, irreplaceable cultural and linguistic competency. Number three, systemic capacity bottlenecks. But the last one is kind of serious too. So county healthcare infrastructures, including valley centers, definitely cannot absorb a massive influx of the community network patients without creating severe medical bottlenecks and extensively dangerous delays in care. And for example, as far as we know, a cancer patient is waiting for 2 months without even being hospitalized for the treatment. And that is very serious. It might bring up to a big lawsuit to the system because of the delay, because of the bottlenecks that create by the single plan policies, and the counties kind of the monopoly the plan to take all the patients, but they couldn't handle them all. So our suggestion to the Santa Clara County Health Advisory Health Plan and the Santa Clara County Board of Supervisors that, number one, expand patient advocacy and transparency. Number two, advocate for the state intervention. Number three, commit to fair provider reimbursement. And number four, protect independent physician networks. That's all I have for today. Thank you for your listening, your time, and your excellent leadership. Once again, thank you very much.
And that concludes public comment.
Thank you. Then moving to item 3, approving of the consent calendar. I don't have anything to add to consent. Do you have anything, Vice Chair? Okay.
Nope.
Can we make a motion?
I'm happy to make a motion to approve the consent calendar.
Great. And now second. No speaker on this, right?
Confirming no request to speak on item 3.
Okay. Let's go ahead and take a vote.
Vice Chairperson Abe-Koga?
Aye.
Chairperson Lee?
Aye as well.
Thank you.
Okay. Item 4 is to receive report from Public Health Department relating to the state of our county's health. And of course, we have our Public Health Officer, Dr. Sarah Rudman. Morning.
Thank you so much, President Lee, Vice Chair Abe-Koga. It's a pleasure to be here, and this is actually, I think, our 3rd year in a row where I've shared some version of this information at our Health and Hospital Committee with the goal of making sure our leadership and our community just has a baseline understanding of what is the health of Santa Clara County, who is having different health outcomes, and what is your public health department doing about it. And so what I'll walk through today are some of the core elements of what a public health department does in reaction to, first, what are the core metrics we look at to know how are we doing as a county. But a framework that I walked through in more detail last year is this image of a stream that we return to over and over again in public health to think about at the far end of the stream mortality. who is dying, of what diseases, at what age, in what circumstances, and then all of our opportunities before that happens to intervene as a public entity, as a public health department, and all of the partners throughout our community who do this work. And so I'll walk through some of these categories later, but you see we can, in the form of our high-quality healthcare system here in Santa Clara County, provide excellent care for folks who have a certain disease or injury, as well as primary care to prevent those in the healthcare setting. But we also intervene at the level of shaping human behavior, their living conditions, the institutions that influence those conditions, and the deep social inequities that might drive those outcomes behind even the institutions that serve us. So you'll hear me reference back to these big buckets where we can intervene as I share this with you today. But ultimately, when you think about what the public health department does, it is not just keep people healthy, but enhance health equity. And what we mean by that is that your neighborhood, your zip code, the color of your skin, the language you speak, your gender, should not be the main defining characteristic of how long you live or the quality of your life. And so when I talk about, in a moment, what leads to the death of our community members, you'll hear me highlight several ways in which we unfortunately don't have this circumstance yet here in Santa Clara County, despite it being the North Star of what we try to do as a public health department and a county. I'll start at the beginning, which is with birth. From birth, and even from pregnancy and conditions before pregnancy, we don't have an equal shot here in Santa Clara County of a long and healthy life. In fact, we see wild disparities specifically by race and ethnicity when we look at infant mortality. This is a trend not just in Santa Clara County, but all over California, all over the country. And as you see with the vertical lines here, overall, our infant mortality for Santa Clara County is lower, is better than the rest of the country. And you may have seen news headlines, a lot of work describing that the country, the United States, has a higher infant mortality rate than many similarly wealthy and high-resourced countries. But you see different communities, in this case described by race and ethnicity, have a different chance at a long and healthy life, even starting from birth. And then as that continues through the rest of life, we see this disparity borne out again when we look by race and ethnicity. We see our Asian community members having a much longer expected lifespan than our African ancestry community members, although there's been slight improvement here over the years. And overall, you'll see that all of these groups in Santa Clara County have a longer life expectancy than the average U.S. life expectancy, which shares and reflects a lot of what we're doing well, doing right here in Santa Clara County. But even within these groups we divide into that can hide further disparities, importantly, that moniker of Asian or Asian American really doesn't do service to the massive disparity and diversity, within our Asian population. When we look by Asian subpopulations, again, we see very different outcomes. For example, our Chinese American communities have much longer life expectancies than, for example, our Vietnamese and Filipino communities. And we monitor as a public health department, not just what we're seeing folks dying, but how are we changing things over time? Now, with everything we do here in the county, it's often humbling to remember there are major historic national or international factors that affect our life expectancy out of proportion to anything we do day to day. So you'll see after 2019, every race, every ethnicity took a major dip during the height of the pandemic when COVID became the #1 cause of death across everywhere in the country, and especially here at home. But you see that the disparities we saw by race and ethnicity worsened during that time and have been slow to recover. For example, our white population took a lesser dip in mortality during the pandemic and was faster to recover than our African ancestry population, which only recovered to pre-COVID levels this year. We see similar trends, although some of the detail is more complex in our Asian subpopulations, with an interesting finding being that actually our Asian Indian populations have had a slower decline and have not recovered to pre-pandemic levels, in fact, have continued to worsen since 2020, whereas other groups have remained largely stable or have rapidly regained any outcomes lost during the early pandemic. Another important way we look at what is the health of Santa Clara County is understanding the causes of death so that we can work backwards from there to say, how do we prevent these deaths, especially early deaths and inequitable deaths? In some ways, while it's heartbreaking to see cancer at the top of this list, we also know that there are many societies, many places, even in this country or many communities, where people don't live long enough for cancer to be a risk. And in fact, in the rest of California and the US, heart disease is the #1 cause of death. So it is in some ways because of our successes in decreasing heart disease risk that cancer remains the #1 cause here. But what I think is especially important to remember is, what are the preventable causes? What are the causes that take lives especially early? And what are the causes that cause particularly inequitable outcomes in mortality? One of the ways we look at this is a metric called potential life years lost. And this is a way of saying, given what folks' life expectancy should be without certain preventable outcomes, what are we losing when folks die of these diseases or conditions? The #1 you'll see here is unintentional injuries, and that includes everything from falls, although often in older populations, to car crashes, drownings, and unintentional overdoses, all of which are preventable and are a target of the work most important to the public health department. But you do see there a good deal of preventable cancers that do take early lives, preventable deaths by heart disease, and certainly by suicide, which is, again, a focus of really everyone here on this dais. Another really striking finding when we look at how are we doing as a county is that in some ways even more drastic than some of our racial and ethnic disparities, we see geographic disparities. And so it's one of the reasons I'm proud to work in a county where we have focused a lot of our healthcare delivery and services in the very areas that have a lesser chance at good health and long life. So you'll see those light-colored areas are the zip codes that have a lower life expectancy. In fact, lower than average for some of our races and ethnicities that are on the lower end of our disparity spectrum. But these are also a lot of the places where we ensure that the county is providing services, a wide range of preventive and treatment options to help people live longer, healthier lives. And then again, we see unequal toll of death, in particular by race and ethnicity, for certain types of deaths. Overdose deaths are particularly disparate, affecting African ancestry residents out of proportion to others. Alcohol-related deaths particularly impact our Latino residents. Homicides affect our Latino residents and also African ancestry. And we do see disparities in heart disease, especially impacting African ancestry residents. So again, in the work that is most important to the public health department, you'll often see us focusing on these types of activities and how we prevent these types of deaths. Now, one of the things President Lee requested of us the last time we shared this information was to really do a deeper dive to understand what is at the core of these disparities. We would like to, and do where we can, everything we can to prevent every cancer death, prevent every heart disease death, prevent every injury death. But it is important to understand what activities, especially in a resource-constrained moment like we're in right now, are most important to sustain so that we do not see these disparities worsen during this time where we are, frankly, under attack in our ability to continue the full-throated push for health for everyone in this county we would like to be constantly doing. And so one of the initiatives that's launched just in the last few months is that the Santa Clara County Public Health Department was invited to join a national cohort, or competed into and was asked to join a national cohort called Cities Lead, working in some of the largest cities across the country with their public health departments and experts in life expectancy data, in policy, and in communication to help look at what policy changes really make the most difference in saving lives and saving lives in an equitable way. And so as this is just kicking off now, I look forward to sharing the findings from that back with this body and with the community. But when I want to share all of the work happening within the public health department right now, one of the things I want to stress for you is that there are so many folks here throughout the entire county who make up the safety net, who say, if anyone is finding themselves in this river, in this stream, we are here to pull you out. We are here to help you. But the true work of the public health department is to keep people from falling into the river in the first place, to say, how far upstream can we possibly act to help prevent disease, injury, and ultimately death? And so I'll share just a few examples of some of what we're doing, especially things that have evolved in the past year that fit into some of those examples. The first is, again, starting with birth and starting with the core social inequities, including racism, that we know drive some of the most disparate outcomes in infant mortality. We have programs like our Perinatal Equity Initiative, our WIC program, which supplies food to pregnant people and their infants and children, and our Black Infant Health program, which is structured around guaranteeing we keep working towards resolving the disparities that impact infant mortality in our communities. When it comes to thinking about the institutions that serve our community in order to make sure that they are doing everything in their power to create equity and counter inequities, one of the core functions of the public health department is community health assessment, going beyond just what are the health outcomes, but what changes would make a difference. And so one example here, again, the board has heard quite a great deal about this year, is the community health worker feasibility study that looked at how do we change the institution of healthcare and community health in order to make sure we are actively battling the disparities we see impacting our Latino community members. We also have made major strides, again with the partnership of folks on this dais here, in the Good Food Purchasing Program, a program that says in order to prevent cancer, in order to prevent heart disease, we need to start with healthy nutritional options, not just the education about how we access those options, but affordable access to these healthy foods. But the way we buy food can also have a positive impact, not just on our bottom line as a healthcare industry, but on the environment. And so this Good Food Purchasing Program not only shifts what food we serve in hospitals and carceral settings to be healthier for everyone eating it, but it's actually better for the environment by focusing more on plant-based foods, local providers, and even supporting the local economy by working with our amazing local farmers we have here in Santa Clara County. We also focus on what policies truly make a difference. And we had some big wins this year, in part coming out of the Latino Health Assessment, but also in part because of our longstanding work through the Healthy Cities program, which works with each of the cities in this county to make sure folks understand what policies are really only feasible at the city level, often not something we can make a major difference with in the county. But if our cities adopt these policies, we can have vast impact on the health and equitable health of their residents. And so we saw a major step forward in reducing tobacco sales, especially focused on areas that children and youth are prone to purchasing, for example, around schools. We saw Campbell, Sunnyvale, Gilroy, and San Jose all take up temporary tobacco shop bans or new ordinances to reduce tobacco sales, especially to our youth. We also work to reduce risk behaviors with things like our harm reduction services, which have some more downstream impact, like things like naloxone and helping people have a life-saving tool on hand at the time of a risk of overdose, but also working with people to change their behaviors in a dignified, supportive way and help people get to recovery with their substance use. And then finally, a core function of the public health department is direct prevention of disease through things like vaccination. And given how many federal policy changes this year have made it confusing and difficult for families to know what vaccines are available to them and important to them, this year we launched a massive public campaign with a lot of partnership from pediatricians all over the county, including at SCVH, to help people understand and remember that vaccination is still just a part of growing up, something we do to take care of our children, to get them back out to their sports teams, to their classes, to their birthday parties, and to being young and healthy. So with that, I'll leave you with a quote from Archbishop Desmond Tutu, which is, "There comes a point where we need to just stop pulling people out of the river. We need to go upstream and find out why they're falling in." And that's really ultimately the purpose of your public health department, and where I'll leave you, and very happy to take any questions. Thank you.
Thank you very much, Dr. Redmond. Let's see, Jess, how many speaker cards do we have on this item?
I have 2 requests online, total of 2 speakers.
Okay, let's do 2 minutes each.
We'll change the timer. Our first speaker is Ken Horowitz. You'll have 2 minutes. Your microphone's on. Go ahead and start your comments.
Good morning. This is Dr. Kent Horowitz of your Health Advisory Commission. And thank you, Dr. Rudman and your team, because I think you get it. Our Health Advisory Commission has been working for over 5 years to look at the root causes of these chronic diseases. And this is why we keep pushing for Santa Clara Valley Healthcare to expand and integrate functional integrative medicine as part of their programs. We're particularly interested in the food medicine program because we think nutrition is a key factor in improving the health disparities. We know that these populations cannot get nutritious foods, and they are consuming foods that are rich in sugars, and fats, and lack the quality that our patients need. So please continue the work of the Health Advisory Commission to expand integrative and functional medicine at all levels of the county health team. Thank you for your time. Have a great meeting.
Our final speaker is Parent. You'll have 2 minutes.
Yes, thank you so much for the presentation. We do have severe health disparities when it comes to children, just their age. They can't protect themselves, and you can see that we're doing a horrible job, you know, in the deaths that we had recently, and Baby Jackson, Aurora Williams, Jordan Walker, and obviously also Baby Phoenix. You know, my own kids are being molested. I reported that my ex-wife was letting somebody rape my son beginning when he was 13. There'd been unnecessary bathing with the children, and there was also sexual contact between 2 of the children. And all this caused my children to be withdrawn, anxious, and depressed. And now the person who is sex trafficking them is threatening to physically harm them. And I can't get the county to do anything about it. I can't get a screening. There's never been an investigation of any kind. I can't even get the county to ask my kids, hey, are you guys okay? Do you guys need anything? Is anybody harming you? Is anybody threatening to harm you? Is anybody sexually abusing you? I mean, just these simple questions I think would suffice, at least for a start. And I'm so glad to hear that Dr. Rudman wants to pull everybody out of the river and help everybody, and she's there for everybody. And so I wanted to ask her, can you please help my kids get a screening? Please. I'm so concerned about my kids, and I know that some of the people here are also parents, and they want the same for their own kids. And I'm asking Dr. Rudman, just as a fellow human being, if you can help me. Otto Lee has all my contact information if you need it. Thank you so much. Thank you.
That concludes public comment.
Thank you. A quick note is that any suspected child abuse or neglect and that type of investigation is prohibited by California law for disclosure of those information. So that's why we are not authorized by law to speak to any specifics of any case or results of investigation. The law also requires that child welfare departments immediately cross-report physical and sexual abuse of children to law enforcement and also the district attorney so that swift action can be taken when needed. The public can be assured that our county takes all allegations of child abuse and neglect very seriously and would take appropriate action. That includes rapid and cross-agency responses to allegations to the Department of Family and Children Services, local law enforcement, the Child Advocacy Center, and also the district attorney. Thank you. All right. Next, yes. So, Vice Chair.
Oh, thank you.
Yes.
Thank you, Chair, and thank you, Dr. Redmond, for this very enlightening presentation and report. Certainly, it's good to see that our county overall is doing well, and we're pretty healthy, especially in comparison to the national averages. But certainly, the disparities among subgroups especially disaggregated by race and ethnicity, is still disturbing, alarming, and I think it also just really illustrates the importance of disaggregating the data. I know there's been attempts to prevent us from doing that, but I appreciate that we continue to do so that we can really target more specifically the areas that we need to work on. I wanted to ask about the changes in the department, in particular, now that your department will be leading suicide prevention efforts and population-level behavioral health prevention work. Can you share, in next year's report, will that information and data be included?
Thank you, Supervisor. Yeah, I think public health is really, frankly, honored to have stepped into the space of thinking at the population level, what are some of the most important things we do to prevent suicide? Of course, we do this in close partnership still with our Behavioral Health Services Division and all of their team, who really cover 90% of the river, the stream I just showed you, where once we recognize that someone has a mental health care need, we will look to their expertise. Or once there has been a tragic outcome, making sure that communities have the support they need is something we'll partner on. What we have seen is a pretty smooth transition so far of the work over to the Public Health Department, where it focuses at the population level. We've been able to successfully meet with all of the contractors and are on track to make sure no break in any of the contracted services as they shift over, as well as seamlessly transitioned the SPOC, the Suicide Prevention Community Group that meets to advise everything we do and make sure we act in accordance with what the community is seeing and experiencing and needs. So yes, I'd be very happy to provide more information on suicide, which again really falls in still sadly within the top 5 causes of death in this county. And another place where we do see disparities by race and ethnicity and geography, and where we see considerable life years lost because this is an outcome that impacts our youth as well as older adults. That said, I also know that we'll be taking many other opportunities to bring additional updates to you, both in partnership with Behavioral Health Services and on our own. I think at this body, as part of my health officer report in December, we'll be doing a more fulsome report at your request, as well as in part with their quarterly reports. So be happy to integrate it here, as well as you'll have more information sooner than next year's report too.
Great. Thank you so much. Yes, I noticed that in terms of potential life lost, it is the 4th, which was rather surprising to me to see. So it makes sense for us to, now I see the integration and how this is going to work quite well. I had it's kind of an odd question, but when we talk about life expectancy and seeing the different data, I see I think the focus is the comparisons among different subgroups, but I was just wondering, what are we trying to achieve with that too? Are we trying to, let's take the Asian category, the different subgroups, and there are disparities. Is the intent to get everyone to the same life expectancy? Or, I guess I'm just trying to understand what the ultimate goal might be.
Right. I mean, I think that's part of why every time we look at data, especially when we do large community assessments like our Latino health assessment, we also need the community voice there to help us interpret what they're experiencing. It matters just as much what the numbers tell us, in fact, probably more, what the community says they want. What is their goal in what their life, not just how long it is, but what it feels like, what opportunities they have. So I think that is at the heart of how we tackle these problems the way we do. Now, I think, fortunately, the trajectory overall, not just in Santa Clara County, but in this country, in this world, is longer and longer life expectancy in general. And that's because of some of the big, big improvements on some of those preventable causes. Everything from vaccines preventing a lot of the infectious diseases that used to really take people in childhood, to things like seatbelts and speed limits that really save us into our young adulthood. So I think our goal is to focus first on the populations with the lowest life expectancy, partially because that is also often where we hear the least opportunity to thrive during that life expectancy. That it's not just we all lived until 82 and died a dignified death with our family around us, but actually we lost community members too young who suffered up until the point of death. And so our goal is to lift those lower lines to the level of the highest, healthiest group. And often when we do that, we actually find everyone becomes even healthier. There's really excellent data on countries who have focused really a vast majority of their resources on, depending on how their communities are divided by geography, by income, by race and ethnicity, on the group that has the least opportunity. And they find that even the groups with the most opportunity still become healthier, live longer, more fulsome lives when that happens.
Yeah. Great, thank you. I recall when I was at the city, this was way back in 2009 era, but we did the Healthy Eating Active Living initiative. I believe the county led that. I saw the information here you provided about that, but is that still going on, or how, has that evolved into this campaign?
There has been evolution. I think sort of some of the history of what activities happen in the public health department has for a very long time been beholden to very narrow focused funding streams that have come down to public health, either from federal or state funders, where they say, you may implement, we recognize there's a particular problem, which we agree is something worth focusing on. We have a recommended program to help combat that problem, something like HEAL, and we'll fund you to do just this program in just this way for some period of time. And so we've seen many of these programs come and go, and what we've tried to do as a public health department is hold on to the most important pieces of it. Hold on to nutrition education, nutrition access as a core function we do. So for example, when CalFresh Healthy Living, the major funding source via the state that went along with HR 1's implementation, the SNAP Ed funding we were receiving, well, officially the CalFresh Healthy Living program has sunset. A huge amount of the community nutrition abilities we built, the relationships we built, the resources we created are going to continue. And so we do our best, even when those resources subside, to continue those. So there are pieces of that program you remember still around in some of the things we're doing in our community nutrition team and in our Healthy Cities program, where we work closely with our cities. There are things we haven't done yet that we need to do. But there are also specific pieces like that program where the resources behind it have sunset.
So I remember when we did that, we were also doing our general plan update, and we had received a grant, this is the city of Mountain View, to integrate a health element. And we ended up instead just sprinkling health initiatives throughout the entire update. But I'm wondering, what do we have, did all the cities take a part in that? And this could be offline, but just curious to see where we are.
Sure.
I'm assuming most cities are now probably getting ready to do another general plan update around this period. So will we be reactivating that?
Right. Exactly how that integrating health in all policies happened at our various city partners differed somewhat city to city. There was and still is this Healthy Cities initiative, which creates as a shortcut to understand how that's been done, a bit of a report card that is public. So anyone can go and look on our Public Health Department website for the Healthy Cities program and see, how does my city measure up in terms of its climate policy, its tobacco policy, its street safety policy, whether folks integrated that policy into a separate health element versus a general plan, I think may have differed. But you're right, just in time for a lot of the general plans to be updated, we are also doing a major update of the Healthy Cities program this year. There'll be a summit to work with city administrators coming up shortly to sort of say, what do you need to succeed? What are you hearing are the most important steps forward your cities need? But also, how are we going to request that you step it up? What are things that 10 years ago when we last designed the report card, we weren't ready to ask of you, but now it's time. And so you'll be seeing in coming weeks an update to our website and updates coming from our city partners.
Great. Thank you. Thank you, Chair.
Yes, thank you for this great report that I always like looking at every year. Thank you again, Dr. Edmond, for the good work. And thanks for following through on getting those data so clearly, especially when it comes to the race ethnicity by this aggregation. I know it's a lot of work to gather those data, but once you see the data clearly, you will finally get to know where the true need is. For example, this myth that Asians are all doing better based on just a big general picture. But when you break it down, you see that the ethnic Filipino and Vietnamese communities have far greater need than what that myth would suggest, for example. And it's telling, right? Even though overall as a county we're doing well, there's still some significant issue once you break it down, number one. Second thing is the black infant death issue that we've been talking about for quite a few years. Even within our county, is still a very real disparity. And so this is something that we need to continue to focus on of how we could do better. I know we're doing better from others, the state and the nation, but certainly from based on what we can see from compared to other ethnicity is still a huge glaring disparity. I want to also thank the staff for answering a lot of questions we presented earlier, and there's a couple of things we want to follow up today. First is, when it comes to addressing disparity, especially in this African American infant death and life expectancy, and some of the other way of located in the Latino and Southeast Asian communities, any additional strategy that the county could look forward to doing to do even better than what we have now?
Well, thank you, Mr. Chair. This particular finding, again, when you look behind it at the actual lives, at the families, at the mothers, at the lives lost, is sort of one of the most heartbreaking. I think one of the greatest improvements has been the launch of our Perinatal Equity Initiative, which layered onto the Black Infant Health Program itself, which was designed to look at the root causes of these disparities and serve individual families in every way needed to overcome them. That's everything from guaranteeing early prenatal care and the kinds of advocacy with their doctors' environments or healthcare environments they need to make sure they're getting care that is unobstructed by racism. But also the kinds of community and supports that that folks who have been left behind historically and frankly harmed by historical institutions, including healthcare, need to recover. But layering on the PEI program allowed us to do two things. One is bring in a number of services that the Black Infant Health Program didn't specifically offer. One was an expansion of doula services, which again, we discussed before the full board in the context of home visitation. And another is mental health care services, because we know there is a deep integration between mental wellness and maternal and infant outcomes, as well as an outsized need in some of the same communities hardest hit by infant mortality disparities. And so we're actually only several years really into that initiative, while frankly trying to overcome decades, if not centuries, of disparities. And we are starting to see some massive changes. I think actually at our own Santa Clara Valley Healthcare, we see pretty incredibly equitable, equal, high birth outcomes for people of all races, infant health outcomes for people of all races. And what the PEI program allowed us to do was start working directly with other healthcare systems, with El Camino, with Kaiser, with Stanford, to make sure that their hospitals had taken the same fulsome approach to guaranteeing top-level healthcare for everyone, regardless of race. So we're just really 2-3 years into that. Now, I think, should there be new resources that come our way, the conversation in front of the board, I guess that was just last week, about home visitation and being able to scale additional home visitation supports to families who don't currently have access to them, is something I would certainly be interested in investing in. But right now, we don't have a way to pivot existing resources without closing higher priority programs to do that.
I guess what I would like to ask is, moving forward, is to identify what those potential initiative might be looking at other jurisdictions of how they are trying to solve the same issue, whether it's LA County or whatnot. And even though we might not have the resources now, I would certainly like to look into, I mean, as you know, I've heard this about public-private partnership issue that I'm working on, trying to do some fundraising from the community, philanthropic ways. I just want to see what out there that's possible, and then that way, let's see how we can find the resources. First of all, is I need to know what the need is, how we could try to meet them, and then with that, I have a story to tell. And that, I think, would allow us to find the resources necessary. I know, look, the federal administration has been helpful this past year, but that certainly does not stop us to work harder to try to find the resources to meet these needs, regardless, right? Second is, the second leading cause of death in our county is heart disease. Anything you want to talk about how we are doing more to work on avoiding more heart disease in our county?
Great, thank you. Well, I mean, I think first, a huge piece of what we do as a county falls to Mr. Lorenz and SCVH in terms of not only treating heart disease and making sure we are there as a safety net to treat everyone, regardless of income, insurance, who is at risk or developing heart disease, and our primary care, which resolves medical conditions that put people at higher risk, whether that's high blood pressure, congestive heart failure, a number of conditions that lead to heart disease. However, a lot of what I described that we are doing does support improved heart disease outcomes. For example, that same good food purchasing program, this very nutrition changes that it promotes, are in line with a heart healthy diet. And when we expand to look at the work of our entire community nutrition team, that benefit grows even larger, that helping people understand what food choices will help them have a healthy heart and reduce their risk of heart disease is a core piece of what we do. Some of the other ways in which we prevent heart disease, I think, are less obvious. For example, and I know Dr. Horowitz listening in would appreciate this, oral health prevention of dental caries, cavities, is one of the core ways we actually prevent heart disease. And so our local oral health program that ensures, starting as early as kindergarten or even age 1 or 2, our community has access to dental care, is core to long-term prevention of heart disease. And then finally, we have a number of programs that support active living and the ability to safely move and exercise, especially outdoors, which all improve heart disease, as well as a lot of our mental health collaborations, which are also major ways that we improve heart disease outcomes. So in some ways, a lot of what you think of as public health interventions for the sake of nutrition, for the sake of exercise, for the sake of mental well-being, those all add up to significant reductions in heart disease and in disparities in heart disease.
Absolutely. Thank you so much. And I think the monitoring of the A1C level is certainly very important. I've learned that regarding diabetes prevention and whatnot. And when you mention oral care, I'm a big fan of having these with me at all times to make sure that my dental oral hygiene is important, because what I've learned is that by flossing daily, it could extend your life by more than 2 years on average, which to me is an incredible statistic for something that simple that matters to our health so much. Second is, I think, as Dr. Horowitz has mentioned regarding the food that we eat, as the saying goes, you are what you eat, right? And so why would you want to put bad stuff in our body? Sometimes, you like to eat some of those potato chips and whatnot. We have those. Moderation is important, but at the same time, at the end of the day, is it extra sugar, extra salt, extra processed food in our food chain? I think has certainly been a huge issue on our day-to-day health side, just to make sure those are the things that we want to advertise and promote better.
Thank you.
Thank you. All right, and then last thing is regarding the issue of overdose and alcoholic related deaths. We still hear about these type of issues from celebrities and whatnot, but certainly it happens even more often in our community day to day. Anything we could do to maybe tailor those to our communities, especially more vulnerable communities?
Mm-hmm. Absolutely. So first, with respect to overdose-related deaths, making sure that everything the Public Health Department does and along with all of its partners and partner county agencies, is tailored to make sure it serves the needs of populations most impacted by overdoses, is at the core of everything we do. So for example, because of the apparent disparity impacting African ancestry and Latino community members, you'll see that some of the recent public information campaigns about what resources are available, where to seek them, and aiming to really destigmatize the concept of addiction or substance use and helping people feel empowered and comfortable seeking the services they deserve, were really tailored to and informed by African ancestry community members, Latino community members, to make sure they saw themselves reflected in the materials we were putting out, that it resonated with the way they talk about their drug use and the way they talk about what recovery and resources they need. When it comes to our alcohol response, I think we are at an inflection point because we have a new relationship with behavioral health services regarding population level alcohol use prevention. A lot of our work previously was focused at the population and policy level, things like alcohol sales licensure. At this point, though, we're really interested both working in partnership through contractors and in novel ways and through a needs assessment that's required by our substance use block grant this year to understand what kinds of resources and population level messages and information are really going to make a difference with these disparities. So I suspect in the next year you'll have both that needs assessment from us that tells us what are the most important things we're going to do with respect to alcohol inequalities this year, and what will that look like for the county.
Good. Thank you very much, Dr. Redmond. And that's all I have. May I have a motion to approve this report?
Yes, I'm happy to make a motion to approve the report.
I'll go and second that.
Vice Chairperson Abekoga?
Aye.
Chairperson Lee?
Aye as well.
Thank you.
Thank you. Moving on to item number 5, which is to receive report from the Emergency Medical Services Agency, EMS, relating to the design of the system and pre-hospital healthcare services. I believe we have here this morning our EMS Director, Nick Clay. Good morning.
Chairperson Lee, good morning. Vice Chair Abekoga, good morning. I am joined today by our Medical Director, Dr. Darcy, our County Executive, John Mills, and Deputy County Executive, John Mills, and our Counsel, Wesley Dodd. So just thank you for the opportunity to come today to you to present the progress on our draft RFP. We have not met since March, so today we hope to give you just a brief overview of the progress we've had since then, as well as just some other key EMS agency developments. But before we go into that, I just do want to acknowledge that we have had some concerns from our partners. We haven't been engaging in a way that they would have expected us to, and it's created some angst and concerns, and I really just want to apologize for that angst and concern as we develop this new system. It's not an ideal scenario. But I want to ensure you that we remain committed to that continued engagement. We've had some great successes over the past several weeks, and we remain committed to maintaining that high level of engagement. Before we jump into the RFP, I do want to give you a brief update on our county ambulance contract update. So since September of 2023, we paused response time compliance due to some challenges with our dispatch system. Those have since been rectified, and as of July 1st, we're now monitoring the response time compliance. And we are pleased to say it has been, combined with that and some other systemic updates, some good progress in terms of response time compliance being improved. So we'll be presenting that data on our website in the next week or so. And as we develop the RFP, it's also really important and make some system changes that we highlight some other clinical advancements that we're not waiting for the RFP to do. And with that, I'll turn over to Dr. Darcy for some high-level overview.
Okay, good morning. I'm Nicole Darcy. I get to talk to you today about the clinical updates that we're focusing on in order to design a system that provides high-quality clinical care and ultimately improves patient health outcomes. And I want to start with that over the last 60 years, EMS has grown. We are not just ambulance drivers. We bring the medical care to the patient at the scene of the accident, of the emergency, of your home, wherever this is happening. And this gives us that unique experience to give expedited medical care within the scope of EMT and paramedic scope of practice. So this brings the medical care from the hospital to the scene, to the patient, to meet the patient where they're at. We initiate treatment, stabilize the patient, and perform those life-saving, time-critical interventions even before you get to the hospital. Therefore, it matters what is done, and how it's done, not just how fast it was done. Now, it matters how it's done. It matters whether it's done and whether it's done successfully. So this brings us to the new focus, which is bringing these clinical performance metrics to the contractual requirements for our provider. Now, it is not just as fast as we can get there, but what we do, which means that we're not just going to be looking at those response time metrics, but we're going to be looking at the clinical care that is delivered when we get there. So what is that? That's the pre-hospital interventions that are time-sensitive interventions that have been proven to improve patient outcomes. And this is not something that is chosen at random. These are the actual interventions that have been shown to improve patient health outcomes in the long term and short term. So that's how these metrics are selected. Some examples. The most obvious one is giving aspirin to patients who are having cardiac chest pain. That means when they're having a heart attack, because the more time that they have with the aspirin in their bloodstream before they go to get the procedure with the cardiologist to open up that blocked artery, the better their outcome is going to be. What EMS does in that moment, giving aspirin early, every time they see a cardiac chest pain patient, that matters. That matters to the system, that matters to health outcomes of the individual, and that matters to health outcomes for the community. Another example would be when you identify a trauma patient meeting trauma criteria, that they get transported to a trauma center. When you identify a stroke, you take that patient to a stroke center. When you identify someone with chest pain, that you do an electrocardiogram to diagnose a heart attack within 10 minutes, which is the same standards that we hold hospitals to, we hold EMS to as well. These are the types of clinical performance metrics that matter for the individual patient and for the community. That is something that we have to push forward. It can't just always be response time metrics. We have to look at the bigger picture because we're not ambulance drivers, we are EMS clinicians. The next exciting piece that we're looking at, and this ties into what Dr. Rudman was saying from the public health mission, is looking at harm reduction. So we get to partner with public health and work with their harm reduction specialists and share that goal of harm reduction for our substance use population. So we'll be rolling out pre-hospital leave-behind naloxone kits and buprenorphine starting this update season, which is starting in the next couple months. This will expand our care of opiate use disorder patients in the pre-hospital setting to, again, meet patients where they are. These are patients that are experiencing an overdose. Maybe they've been reversed with naloxone by the paramedic doing that life-saving intervention, by that law enforcement officer, but now they're suffering from withdrawal, and this is that kind of suffering that we can alleviate. And instead of going back to their opiate of choice, now they have the option to be connected with this medication from the paramedic in real time, as well as connecting them to those resources that our county offers for opiate use disorder, further treatment, and relief of those symptoms to link them with ongoing care. So we applied to the state and we were approved, which was very exciting, for this expanded scope of practice for our paramedics within Santa Clara County to give buprenorphine in the field. So that will be rolling out. Now the next topic of clinical care advances is this idea of matching resources. And I wanted to start with setting the scene that not all 911 calls need red lights and sirens and are actual emergent medical conditions. And that can be a bit of a jarring realization to think that not every 911 call is that critical medical emergency that requires red lights and sirens. In fact, the majority of our 911 calls are not. And how do we match the actual acuity of the patient calling, of that 911 caller, with the appropriate resource to get them what they need without burdening them with the full response of a full system. A lot of this has to do with the struggles and burdens on our entire healthcare system. It is hard to access primary care. Sometimes it will take months and months to get an appointment with your primary doctor. Or maybe you lost your job and you lost insurance and you no longer even know who your primary care doctor would be or how to access care. Urgent cares are full. Emergency departments are full. The safety net has become the emergency department, and the safety net for how to get there is 911. So how do we actually grow our system? How do we grow and evolve to meet the new and evolving needs of the vast spectrum of patients that are calling 911? We need to expand and evolve the services that we offer. And we have to design a system that matches patients to the appropriate resource that they need in that moment. So one of the big steps that we have to do, and this project is very exciting, we get to look at the last 7 years of data, and we get to see the correlation between the code that the 911 dispatcher identifies when they ask the questions of the caller. When you call 911, they ask you questions, and they get to narrow in on what's going on for that caller. Then they currently use that information to dispatch a resource. Now we get to refine that mapping of what that code is to what resource gets sent to really match resources and patient needs. And the reason this is so important is because both over triage and under triage have adverse effects and costs. If we under triage, we are burdening our first responders with spending more time with a patient, not being available for their next call. But if we over triage, then we are burdening our patients with the financial cost of the readiness of the system. So we have to balance that. And this is new for our county, but it's not new to EMS or EMS systems, and it's well described in EMS literature. For example, just like sending a helicopter to every 911 call is not the appropriate response, it's expensive, it's burdensome, we can't have that full response to every call. Another pathway to upgrade our system design to better match resources is to expand our nurse telehealth program to all jurisdictions. At the dispatch level, this is an example of a resource that we currently have. It is valuable in matching patients who don't require those full 911 resources and connect them with non-911 services. So that means a telehealth visit, a ride share to a urgent care, an appointment with a time, or even a non-911 ambulance being sent at a non-911 speed to them, but still always connecting them with care, with the answers they need. Currently, this is only available at select dispatch centers in our county, but expanding this to all dispatch centers is an example of a huge win for equitable service delivery to all of our communities. EDs are the most expensive way to get care, and 911 is the most expensive way to get there. We can do better to match resources and meet patients' needs where they're at. So, in closing for me, we, as the EMS system, are committed to elevating pre-hospital care to the best practices and evidence-based medical care, and our goal is to provide patient-centered care, track patient-centered metrics that improve patient health outcomes. Using data-driven decision-making, we can attain that world-class pre-hospital care that our community deserves. Thank you.
Thank you, Dr. Darcy. It's a great sort of segue as we ramp up into launching the RFP and subsequently the new contract. So I want to talk about public engagement, our public comment process. So when we last came to you in March, we had anticipated coming to the board in full board in June to discuss the RFP. However, we had an opportunity to not come in June, which gave us then a really great opportunity to engage our stakeholders. We were able to then publicly post the draft RFP, allowed 3 weeks of public comment. We distributed that opportunity to over 350 different EMS providers, and then again asked them to even forward that even farther. At the end of the 3-week period, we received 16 submissions of comments, one of which was blank, so technically 15 submissions of comments. Then divided those into actionable and non-actionable items. We had some that were simply just statements or positional statements. Some were technical advice, and then some were actionable items for us to update the RFP. Some themes that came through were strengthening the tiered response and to mitigate the impacts of low acuity ambulances arriving to high acuity patients, like Dr. Darcy's project just mentioned. Was protecting the use of the fire department surge ambulances, increased engagement with our hospital partners, increased levels of reporting and transparency in data, supporting expanding access to healthcare, and then protecting the fire department ALS support payments that we're currently engaged in. In addition to that, the comments received in that 3-week period, we also received a letter from the Fire Chiefs Association towards the end of that comment period. We met with them on August 5th for about 3 hours. We're able to go through point by point all of their concerns, find common points of alignment, of which I will say there are a number of points of alignment between the RFP and their stance and position, develop mutual understanding of what the system looks like today, as well as identify opportunities for us to update the draft RFP. Subsequent day on the 6th, we sent them draft language for review based on that meeting to really try to move the needle forward. And as of yesterday, we did receive comments back from them, so we plan on meeting with them hopefully between now and Monday to engage on those comments and really address additional concerns they may have with the RFP. And while there are concerns, those concerns raised with the RFP, I think it's really important to highlight points of alignment and the highlight of the RFP. The new emergency response zones we built, so currently we have 5 emergency response zones, which is how we measure response time compliance. They were built in 1995. They have not evolved as our communities have evolved. So through a delightful partnership with Public Health Science Branch, we're able to deep dive through years of data, look at Healthy Places Index, impacts to communities, response time, response volumes, and really try to ensure that we have an equitable level of service. And with that, we actually were able to create 6 zones, one of which is isolated to downtown San Jose, that really ensures that downtown San Jose, 1, gets its service as a busy area, but then 2, protects the more outlying areas from the volume and resource impacts of downtown. We have increased jurisdictional reporting as a part of our RFP. We've really shifted from the idea of normalizing liquidated damages for response times, whereas in today's environment, if our current contractor provider is late, we levy liquidated damages, and we do that back and forth and back and forth. Through the RFP process, we've developed a much more proactive root cause analysis process that as they have repeated noncompliance, we do a root cause analysis. We ask for additional unit hours, and we try to solve the problem versus just creating liquidated damages as a part of doing business. We've looked at the tiered response model, again, looking at making sure the right resources are sent to the right time, or the right patient at the right time, but ensuring that low acuity patients receive low acuity resources and that high acuity patients receive high acuity resources, meaning if we determine a patient requires a paramedic, that they aren't getting an EMT ambulance or non-paramedic ambulance. That is a requirement in the RFP. It's prohibited to send an EMT ambulance to a paramedic level patient. And a variety of other elements to really ensure that we have a cohesive system. Our fire department partners have really put forth a tremendous effort with our surge and contingency ambulances. A huge value add when we went to challenges with paramedic level staffing and ambulance responses during COVID and subsequently thereafter. We want to leverage and value that investment, but in a way that's meaningful for them and that meets their unique and distinct operational needs throughout the county. We also have workforce protections in place. And lastly, there's a lot of alignment around developing a modern, clinically strong, equitable, and accountable EMS system. So I think we are very close to the finish line here. Our next steps, obviously, are engaging the next week with the fire department. We have slated to come to the full board on August 25th, share this update on our process as well as a subsidiary review of the RFP. Once complete, we will then send this to the state, and this is the part of the process we cannot control. The state is required to approve the ambulance RFP as well as our EMS plan concurrently. That process, at the minimum, that will take the state 6 months, is on a first come, first served basis. So if there are 9 RFPs in front of us, which was the current report from the EMS Authority Director last week, that means we are 10th in line. And that means it could take 6 months, it could take 9 months, it could take even longer. We are proactively engaged with the EMS Authority Director. We will be proactively engaged as we submit this RFP to reduce that timeline. But we are up against some challenges with not being able to control that timeline. But we'll work on the assumption that we have a 6-month turnaround window. We'll then receive that RFP back from the state. Any changes once the state has approved the RFP must then go back to the state for review, and that whole review cycle then starts all over again. From there, hopefully we receive it back in 6 months. We would then launch the RFP for an actual procurement process in April of 2027. That's a several-month process. We would then have an intent to award, negotiate the agreement with the bidder. One of the things we're doing to help shorten the negotiation period is to release the draft contract with the RFP and request an attestation from bidders that they would agree or have minimal changes to that contract so that we can shorten that negotiation window so that we can still maintain our timeline should we have some delays from the state. And we expect to present the resulting contract to the full board by the end of 2027. You may be asking yourself, well, if this contract goes until 2029, why are we behind schedule if we're going to be done by 2027? And that's because to maintain a competitive procurement process, especially for a county of this size and complexity, it's about a 1-year ramp-up period for most ambulance providers, especially given the number of ambulances they'll be needing to procure. Even if we think it's about 70 ambulances required at a minimum, give or take, to procure to provide service here. Even if you were to buy 70 Honda Civics, that would take you a fair amount of time. But ambulances are custom built, not off of the shelf, made to order items. So that just takes time to procure those for the full deployment required to meet the county's needs, let alone the infrastructure requirements of procuring buildings and deployment centers, et cetera, and staff. So the 1-year period is there to protect a new provider should they win the bid to be able to provide service. That service would then take effect January 1st, 2029. In closing, change is exciting. It's an opportunity, but it also creates angst, not only in this room with our partners, but also with our patients. And we are laser focused as we go through this process to help all folks really understand these changes and to help get excited about the updates and changes of our system. We've also received overwhelming feedback that maintaining the status quo of the soon-to-be 18-year-old agreement is just simply not acceptable. Throughout all of the RFP comments that we've received, a lot of concerns were raised about how today's system works and how this RFP needs to ensure that it addresses today's challenges. We designed this system in 2010. It'll be old enough to vote by the time it's over. It's just too long. The system, our community has dramatically changed in the past 16 years and soon to be 18 years. The RFP advances that needle. Even if it's not perfect, it advances the needle to a much better place than we are today and allows us to continue to advance that needle to make sure we're getting the right patient care and delivery and modernizing our EMS system. It establishes a new foundation, increases service delivery, advances equity, and really provides a new lens for us to review the EMS system. So with that, I will close and certainly open to any questions and concerns and comments you may have.
Thank you. Yes, good, James.
Yeah, I just wanted to share a couple additional comments and just acknowledge that what a significant lift this is for the county EMS agency, which is a very, very small department, and their RFP process is something that only happens on a periodic basis, and this county hasn't actually really happened in quite a long time now. But a lot of challenges that the county EMS agency faces operating under the current structure. And as I think about it, I think about this RFP as a bridge, transitional bridge to different ways of thinking about our EMS system. And the need for moving forward with that transitional bridge has been made to me quite compellingly in my conversations with the EMS agency, given the constraints that the current system has under the current framework and the really significant improvements that'll be made under the current RFP structure, including the introduction of clinical standards, as was discussed by Dr. Darcy, but also the reconfiguration of zones, and perhaps most importantly, from my perspective, given my experience as county council, the introduction of a whole suite of remedies, so to speak, that add to, don't take away from, but add to a liquidated damages framework that has fundamentally not resulted in sufficient performance behavior changes over the duration of the current contract, but instead has resulted in payments of damages when the actual intent is to get performance, not to collect liquidated damages. So this doesn't remove the liquidated damages, but adds a different layer that I think will really give us tools to hold the contractor accountable to performance delivery that just don't exist under the current structure. So all of that, I think, is very positive. There are limitations in the current broader framework, and I just want to take a minute to say how frustrated I am with what has been a many multi-year delay on the part of the state in updating the state regulatory framework for EMS. We have been promised, and I have spoken about it in these chambers literally for years now, that there would be imminent, complete changes based on court decisions that threw out the state EMS authority's framework for managing the state EMS system. There was a pretty important court decision many years back now. I want to say it's been 4 or 5 plus years at least, right, Wes? That said that the state was basically acting on what are called underground regulations. They had a whole framework that they were using, but it was never adopted as official regulations, and the court bounced all of that. And since then, they tomorrow, there's supposed to have been a new updated regulatory framework, which then we have to work within. It's still not here. And that's a really serious problem because it means the whole state framework that we're forced to operate under is really out of date and provides a lot of constraints and has created a lot of, this is my opinion, chaos across the state. It's one of the reasons why county after county across the state has faced litigation associated with RFP processes. It is not a good structure. And so the EMS authority needs to fix that. Maybe with the new gubernatorial administration they will, who knows. But it's not going to be in time for us right now. That's pretty clear. But I wanted to name that too because that has had really significant impacts on the operation of our system, but also the framework within which we have to operate right now for the delivery of EMS service. So hopefully a lot of that will change in the coming years, as well as opportunities to reimagine the system in a different way. But I do think it's important to move forward with the RFP process itself, given the age of the current contractual framework and the consensus, I think, across all critical stakeholders, hospitals, fire departments, others, that the current framework is really outdated and needs a substantial upgrade, even if the upgrade is not going to address everybody's concerns with the current broader structure.
Thank you, James. Jess, anybody would like to speak on this item on the?
Confirming no request to speak on item 5.
None in person and no one on Zoom.
That's correct.
Wow. Okay, that was surprising. Yes, Vice Chair, do you have some questions?
Thank you, Chair. And thank you for the presentation. I appreciate all the hard work that's been put into this process. I've mentioned before that I've followed this, the EMS and transport issue for 17, 18 years now, and seen the contract come up every so often, the amendments, and after, as mentioned, 18 years, I felt it's important for us to go out for an RFP, and if you recall, I did bring that up last year, my concerns about the having enough time to do a full process, and that had tied into the survey that was done, and my concern of working on that, delaying this process. I hate to say it, but I think that did come to fruition to some extent, and I do appreciate the outreach that's been done more recently to our fire chiefs and our city managers, but knowing, coming from a city, the true partnership that's involved and necessitated in this program, EMS response, I really do think, it's critical for us to be working with our partners and being responsive to all of their issues and concerns. It seems like most of that has been resolved, and I appreciate especially that 3-hour meeting that you had, Director Clay, with our cities. I believe there's a few other questions still left to be answered. I wanted to ask a few of them that have come to the top of my mind from my conversations with and my outreach to our various stakeholders. But I guess to be honest, I'm a little concerned that this is coming to the board on Tuesday, and not really sure if we're ready for prime time yet. My preference would have been to have all of this worked out. I know some of it can perhaps be worked out after the RFP is released, but I just saw the draft of the newest version came out last night. I was going to bed at 11:30, happened to look at my email and saw it was posted then. So I have not had a chance to look at it. I'd like to request that we have a red line version of that, because I'd like to see the comparisons, the differences. My main interest is that we do respond to all of the questions and concerns that have been raised, and then if there are areas of disagreement, which I can, imagine there will be, for me to understand what our reasoning is for that, so that we can respond accordingly. The questions I have, the main one that I've heard mostly is the issue of the provider subcontracting with each of the agencies that will provide the transport. So the fire departments. I sent an email to you asking about other examples of that in other counties, and I read your response and I didn't quite understand it. You mentioned you did a survey, and are there other agencies that do have this arrangement?
Yes, Vice Chair Abekoga. So based on your question, we did reach out. There's 34 EMS agencies across the state. So we reached out to the 33 others. Not all of them run ambulance RFPs. Not all of them have exclusive operating areas. Some have non-exclusive operating areas. So we reached out to find the ones that are similar to us, that have an exclusive operating area with one provider within a geographic area, and asked how you made this successful. And really the constraint that we see is that in order to have an exclusive operating area, it is exclusive. You have one provider that serves a geography. And some of the benefits of that really is the cost recovery is fixed. So there's only so many ambulance responses to be had within a certain geography, and only so much reimbursement that comes through the complex versions of government reimbursement, commercial payers, and private pay. So with that, you sort of have a ceiling as to how much revenue can be in the system. And that's really the benefit of providing that sort of monopoly, which is protected by state law through the Health and Safety Code, that allows us to provide a monopoly for a geographic region, because we're going to place performance demands on that provider to then receive that monopoly and to provide that service and that revenue. So in order to protect that, you need to make sure that it's exclusive. To do that really means if you can't sort of have one provider but then other providers who don't belong under the umbrella of that exclusive operating provider. So you have one provider. There are other jurisdictions that do similar setups, and where you have a subcontract. So Acme Ambulance provides the service, subcontracts with jurisdiction A to provide some level of service. Others do what's called a mutual aid agreement that essentially says, very similar, just framed differently, that they'll provide mutual aid. If Acme Ambulance can't be there, then jurisdiction A by automatic aid will provide service. Those are all framed as agreements. They're all through the approval of the EMS agency to ensure, again, compliance with health and safety code. So it's really designed to, two things really sort of the intent of that RFP language. One is to protect the exclusive operating area, but two, as we discovered in our Fire Chiefs Association meeting, all of them utilize and staff those ambulances in very different ways. There are some jurisdictions that they're staffed full-time with 2 providers dedicated to the ambulance. There are some that actually take the firefighters off of a fire engine, preventing that resource from doing its full capability and putting them on an ambulance. So it's very challenging for us to create a standardized agreement that accomplishes what those jurisdictions do, from Gilroy to Mountain View to Santa Clara to San Jose, all operate differently. Hard for us to say, here's the box that everyone has to fit in when they all need that flexibility to navigate them differently. The third tangent to this and challenge is in today's environment, the jurisdictions don't see where the ambulance is. So if a call comes out on 1234 Main Street, they're sending their jurisdictional ambulance. It may be the closest ambulance, but it may also be bypassing 1, 2, 3 ambulances on the way to that call. So we lose the benefit of sending the closest, fastest, most appropriate ambulance to that patient because they can't see each other. So by creating that arrangement, we then are requiring that they're able to see each other so that we know we're sending the closest, fastest, most appropriate ambulance to that patient.
Thank you for that. I guess the question and the concern is from the agencies, the ability to negotiate an agreement with the provider, and like, how do we ensure that they're equitable across the different jurisdictions? You mentioned uniformity or the lack of. I think I'd say there's interest in providing more of that. So I guess I'm trying to understand this relationship now. If it used to be EMS would do that negotiation and have a overall agreement, now you're asking each of the agencies to go and do their own?
Yeah, so it's actually a
specifically?
really great distinction that we had the opportunity to clarify. So state law requires that the EMS agency has an agreement with ALS providers. So if you want to provide paramedic level service, you have to have an agreement with the EMS agency. That requirement remains whole. We're not changing that. We're not supplanting that with a provider agreement with the contracted ambulance provider. So we have those agreements. And what those agreements basically say is we are authorizing jurisdiction A or provider B to provide paramedic level service. And there's certain requirements they have to follow. What was actually contemplated in 2020 in one of our amendments was the requirement for AMR to contract with the fire departments. That was a requirement that was set forth almost 6 years ago, has not come to fruition yet. But what we've put forth in the RFP is that requirement should sustain, that there's an exchange of service, whether that's the provision of ambulance service or arriving first and allowing the ambulance provider to have a little extra time to get there. There's a service and an exchange of funds. And we feel that it's really important that there's an agreement that the jurisdiction is providing a service, has a contractual relationship with the entity they're receiving funds for. We really think that's an important opportunity, one, for the provider to make sure it's very clear what service they're receiving, and two, very clear from the jurisdiction's perspective, the service they're expected to deliver for those funds. The RFP does require that those are approved through the EMS agency, and section 12.5 of the RFP actually outlines about 10 or 12 requirements for both the ambulance provider and the jurisdictional fire departments. What we sent them on August 6th was some additional framework. So if there's additional need for standardization, we remain open to hear what those are. I certainly don't want to presume to know what each jurisdiction needs or what the collective requirements are for the fire departments. Certainly would welcome that feedback for specific language that we want to see in those either pre-baked subcontracts or the RFP itself.
Okay, thank you. One of the other issues around all of these agreements, and I've seen it elsewhere too, is the escalation process. So what do we do when there is disagreement?
Just for clarification, Vice Chair, the disagreement between the first responders and the entity for the subcontracts?
Yes.
Yeah, so I think that's part of that, their request for that standardization, which I think makes a lot of sense, and certainly requiring EMS agency approval. I think the consequences of not having a subcontract agreement is really twofold. One is the ambulance will get there 4 minutes faster because the requirement changes from 11 minutes and 59 seconds to 7 minutes and 59 seconds. So potentially it's a positive, right? I mean, the consequence would be faster ambulance. The negative obviously would be the financial exchange, right? So there would not be that financial exchange. I mean, I think we had to figure out what is 4 minutes worth to each jurisdiction. Again, I can't presume to know what that is for each jurisdiction. I can't presume to know what 4 minutes is valued for the ambulance provider. So we can certainly create that framework, but any disagreements would come to our office to help adjudicate. And certainly our goal would be to be a middle provider to help adjudicate that. But at the end of the day, I think the consequence would be no agreement means the ambulance is there faster.
Okay, thank you. Regarding the fire surge ambulance capacity, I've been told that right now there's no uniformity. It's like whoever can provide it, whenever they can provide it. Are we working to provide more clarity on our expectations and?
Yeah, I think it just, Vice Chair, goes back to how each jurisdiction wants to use those ambulances. So there's a jurisdiction that has only 3 fire engines, and when they use a surge ambulance, they're downing a fire engine for their community and then putting them on an ambulance. There's other jurisdictions that staff them 5 days a week with 2 providers full-time, and they're not impacting their fire service or all hazards response. It's hard for us, again, to sort of, one, I can't mandate that by any stretch, and certainly we want to ensure they have the flexibility to do what they operationally need to do. So I'm not really sure where the conflict is between the RFP language and that requirement, because again, we don't want to mandate something that then is an unfunded mandate to staff an ambulance that then puts that jurisdiction at a financial hardship.
Yeah, so I think the issue here is that, right now it is sort of dependent on availability or whatnot, and that's where we get disparity because some cities can afford to even have an ambulance and some can't. And so then that ties into the private provider because they're, number one, it's really their responsibility, but right, like how do we ensure equity of the provision of services and not having certain agencies have to cover more of the cost? So this is, all really tied to, and this has been my real issue for many years, coming from a city, it's like in terms of cost recovery, there is no full cost recovery to the public agencies. And, why do we, as a public agency, have to frankly, subsidize a private provider? Like, that's the ultimate issue that I think we're all trying to get to here.
And that's, I think, one of the real reasons that this RFP is, I think, going to be really helpful, because what the situation is today under the current system is that there's no contractual relationship between the provider and the cities. Some city fire departments have chosen voluntarily to staff and put ambulances in service and respond to calls. Because there's no contractual relationship, those are not ambulances that are being compensated as system ambulances. And so what's happening is exactly what you're describing. With this RFP, the provider, whoever the winning bidder is going to be responsible. We have much better tools to impose remedies if there's non-compliance, because today the tool is basically liquidated damages or terminate the contract, and terminating the contract is an important remedy, but not a very useful one if you're trying to improve performance.
Yeah.
So those remedies remain, but we're adding a whole menu of additional remedies that include obligations to add service units into the system if they're not meeting performance standards, that actually would force additional service units in the system. That's missing today. That's not a tool in the toolbox today.
Okay.
So that's one really powerful piece. The second is, if the provider is going to rely on fire department ambulances, they can do so. So we're not banning that, right? They can do so, but they need to have an agreement with the city. Presumably the city's going to say, you better pay us for that, right? Now that's obviously, I suppose a city could choose to say, we'll provide it for a discount. I wouldn't if I was a city. But they have to have an agreement, and then most importantly, that ambulance becomes part of the system. So now it's actually being dispatched as part of the system, and essentially it's now the provider, whoever the provider is, buying that resource from the city fire department. So that's not something that exists in the current framework at all. So I think it actually is directly responsive to this concern. And I think the point that Nick was raising is the reality is the different fire departments in our county have different things they want to do in that vein. So there's some jurisdictions like Mountain View and San Jose that have ambulances. There's other fire departments that don't. We have one really large jurisdiction, Sunnyvale, that has a completely different response model altogether. So, you know, we have to accommodate all of that within the framework of the RFP. And so what we've tried to do is have minimum performance standards for those agreements. The agreements do have to be approved by the EMS agency, so there can't be some crazy something that's way out of alignment, but they can be customized. So Mountain View could have a different arrangement than San Jose, than Gilroy, knowing that the ability of those departments to staff their apparatus look different between each of those jurisdictions, for example. So I think it will, I don't think it'll, this is my take again, I don't think it'll be perfect, but I think it'll be a massive improvement from what we have today, and a massive improvement in leverage for the fire departments in those conversations. And most importantly, we will have much better tools to actually ensure performance, because the real issue that we need to be seeing is available resources to respond to the calls as call volume changes. And what happened is call volume in this county is so much higher than it was in 2010 when the system was designed. And so the design of the system hasn't kept pace with that. And obviously that'll reset with the new data, with 2026 data, but that'll keep changing right over time. And so we need the tools to make it dynamic over time. And I think this gives us much better tools to do that. Although I'll just tell you, I don't think this is the perfect system design for EMS, but I do think this is a massive improvement on what we have today.
Thank you. So the request is if there is an example of this new system model, the fire chiefs would like to see it. They are not aware of one, so I believe. So if we can provide a county or someplace that has this, that would be very helpful. The next, and I apologize that I'm taking a while, but the other issue is, well, as we talked about this and moving away from liquidated damages to performance-based. So I guess I see that there's, again, a fundamental conflict there because, and it goes back to the issue of private provider versus public providers. And the concern here is that, are we now actually requiring too much or potentially too much? There's some concern about the nurse navigator program and requiring that from the provider, that we would not get enough bids. Or it sounds like there's only maybe 2 providers out there that actually have a nurse navigator program. So, and then I'm curious because I know the last time you went out to bid, I think you told me that we didn't get any bids. And so that's the other flip side to this, right?
It's funny you mentioned that specifically because the nurse navigator program was actually made, was made optional for that reason, which is we're trying to strike that balance. The reality is only a handful of entities are capable of realistically serving a community our size, and that's because of the broader market forces. So the pool of bidders, the theoretical pool of bidders is not that large, and it has shrunk. Rural Metro, which won the this underlying contract, got bought out by AMR. So we've had a lot of consolidation. And so the theoretical pool of bidders, I think everyone recognizes is at best a handful. But we do want to make sure we're striking the right balance between demanding everything that we need to be demanding for the community without foreclosing competitive bids because we want there to be multiple bidders. That's a very good thing for us. So now, did we get that perfect? I don't know. The potential bidders got copies of the draft RFP too, and maybe they were people who submitted some of the comments. I don't think they did, but maybe they did. But they certainly could have, and I would hope that they would have told us if they saw something that was a deal breaker that would mean they couldn't bid. But we're trying to find exactly that kind of balance. And the more costs we impose by way of either performance standards or structure or other agreements or subcontractor arrangements, et cetera, the harder it is obviously on a provider, but we want those things that we need for service delivery. So hopefully we've struck the right balance, but we're not going to really know until it goes out to bid. But we've tried to be mindful of that thoughtfully, and we've tried to make some of the requirements exemplary instead of mandatory, if that makes sense. In other words, signal that if you do these kinds of things, you're likely to get more points, you're likely to fare better, but we're not going to disqualify your bid if you don't have it. And nurse navigation is an example of that. We think we'd like to see it. It's probably going to give you more points, but we're not going to disqualify you if you don't have it. And there's several things like that in the framework of the RFP.
Okay, great.
And I would just add,
Thank you.
actually, if I may,
Yes.
Nurse Navigator is a great example of an area that we don't have equity in today. It serves a very small subset of our communities where it could serve the entire county tomorrow
Right.
at really no cost to anybody. So it's something that we think if we can really promulgate Nurse Navigator across the county, it almost then forces bidders to say it's a service that's countywide today. We must put it into our bid to ensure it's countywide tomorrow. Whereas today, it's such a small subset, it's unlikely that anyone would say it's a requirement.
Okay, great. Well, thank you. I'll just leave my questions to that. Thank you, Chair, for your indulgence. I certainly agree, and I see the challenges that we're trying to transform as the industry has transformed. I will say I very much appreciate County Executive, your comments about looking forward to the next round, the next iteration, and really looking at how we need to probably reimagine, redesign EMS service. And what I would ask is that we make sure to include our stakeholders and start some kind of ad hoc or task force or something to begin that conversation, because frankly it does take many years to do, and I don't want to be put in the position here where, again, maybe we're ready to go on Tuesday, but it does feel rushed, and I think everyone would have appreciated more time to provide comments and have that conversation. So I really would like for us to get started on the next iteration soon.
I think we definitely should. I do think it's a multi-year project, and like I said, I really envision this as a bridge. We will provide a red line so that that's available for folks to see, and continue to try to respond to whatever other feedback there is. But do feel that there's some urgency to try to start the clock at the state level because we don't know how long it will take, and I think we're skeptical the state will actually handle it in the 6-month timeline that they have said they will. So,
Do we have a plan B in case something like that slides and we don't get to the start date of January 29?
we'll need to negotiate another extension with the current provider, and I'm sure we'll get another extension with the current provider. It will undoubtedly continue to have all of the challenges that we currently have.
Okay. Thank you. Thank you, Chair.
Yes, thank you, Vice Chair. I just want to say I echo many of the concerns raised by my Vice Chair. So you've asked a lot of the questions I was going to ask today. But I just want to make sure everybody understood that these concerns are shared by not just us two, and I'm sure many of those in communities have been talking about that. As we have talked about this RFP, certainly this RFP has been long overdue. When I mean long overdue is usually it's like a year or two. In this case, what's really unique is that this is actually a contract based off of a RFP from 2010, right? And that there was an RFP actually went out in 2017 approximately, but there were no bidders,
Correct.
right? And that's what I call an unsuccessful RFP. And certainly,
Yes.
we don't want that to ever happen again when we're doing this. And that's why I think it's so important to have the stakeholders' input and making sure that we have not just one, but hopefully multiple bidders, right? As the slogan says, when banks compete, you win. It's no different from what we're doing here. If we only can end up with one bidder, that's not exactly a good thing either. Right,
Yeah,
James?
like I said, we're trying to strike that balance. I'm a little anxious because, almost all the stakeholder feedback comes from our cities and our hospitals. And so that feedback moves in one direction, which is more things that people would like to see the system deliver. And that makes sense. I'm not saying that in a negative sense. I'm saying that that's the lens that most of the stakeholders are operating from. And so we don't actually have, they have the opportunity. Like I said, this was a public feedback process, but I don't know that we really have good insight into the extent to which there could be concerns from prospective bidders.
Mm-hmm.
It's hard for us to do much to get that feedback beyond what we've already done, which is we opened it up to the world, and hopefully they've let us know if there's something that looks like it's going to be a serious problem. So we're hoping that it is competitive, but I couldn't agree with you more, having been here through that last process. It was a lot of work and didn't result in anything. And so we continued with a system that we had issues with. And so that now here we are today, and it's that same underlying system. So, we do need to have a competitive RFP process.
Right, and like this is 9 years ago, like
Yeah.
RFP. That's why I said this is so long overdue. Number one. Second
Back
of all,
then, we were going to have regulations and a new framework from the state imminently, just to give a sense of how long we've been waiting on the state. So,
yeah, and as we are having a aging population, the need of EMS services is crucial. And at the end of the day, in terms of the mission of what the county does, this is our bread and butter, right? All the cities rely on 15-town cities. This is something that is core to our mission of the hospital trauma services. This is absolutely part of it. So I think this is one thing that's so important. I guess my concern, as the vice chair has mentioned, was that how rushed this was in terms of getting inputs, with like initially 2 weeks and then extended to 3 weeks. And I really do hope that this discussion would continue. I want to specifically thank the Fire Chiefs Association and namely the president with Chief Rob Fleeup for spearheading a lot of these communications back to us to make sure that these communications keep going on to identify those issues. I know that was a long letter, but certainly they may or may not have addressed every single issue that we need to deal with, but I believe a lot of those have been addressed in this short amount of time, which is pretty incredible given the fact that July is supposed to be a recess month. So I know you guys work very hard, and them as well, the city managers that took time off from their recess to make this happen. I want to also make sure that the commitment to outreach is going to be continued moving forward, because obviously there are still things that we need to work on. In terms of the flexibility of RFP that you mentioned, I think it's very helpful because as we have seen with the 15,000 cities we have with so many different fire departments, everybody has a different way of doing it. The city I live in Sunnyvale, our fireman is a policeman and policeman fireman, but they are not paramedics. They are EMTs, right? These are level of services, and of course, so that model is completely different from what San Jose would do or Mount View would do. So I just want to make sure that this RFP, when we build it, will have these structural flexibility to allow each jurisdiction to put in what they need in order to meet the needs of their residents of the system. Go ahead, James.
yeah, and that's kind of one of the other challenges with the the RFP process, including some of the feedback from the fire chiefs, is to how do you standardize and allow flexibility at the same time? And so I think what has been attempted is to set some core standards, but otherwise leave things flexible as much as possible to account for all of these differences that exist. So, you know, will that be perfect? Probably not, but it's a huge improvement on what we have now. And I do just want to flag two things that I think are really good improvements that we should celebrate. One is the clinical standards piece that doesn't exist today at all and is very important in terms of quality of care. But the other is we've, in partnership with Public Health, EMS agency redesigned the response time zones to reflect the changes in the county population and how that's looked since 2010. And that should significantly improve system performance as well. And I think that change alone will be a really positive one for the overall system in terms of time of response, but also quality of response.
Good. And I also want to highlight and thank Dr. Darcy for mentioning some of the fundamental issues regarding 911 calls. Sometimes people think that, you know, always sending an ambulance out with all those bells and whistles and level of service is a good thing. But what we've learned, of course, is that when you over triage, sending basically over resources to calls that does not require it, what it does is it puts a strain into a system that does not have enough resources, so that those who need those resources for real life or death situations would not have the resource, which means they could be delayed and people potentially could die because of the lack of resources. I think that's a very important point that you've made, and that given where we are right now with technology and with AI and everything that we are implementing in our daily lives, there are ways we can improve the efficiency of making sure the right resources is going to where the need is and not just the most expensive resources, not to even mention the financial cost potentially being incurred for those who are making those calls. I still very much remember one time when I was walking up on the bus in law school, and this lady who stepped on the bus literally blanked out and fell back on the ground. And of course, first thing when something like that happens, right, this is a like brain injury potentially hitting the head on the pavement, and she's just passed out. The first thing we say, somebody call 911. And I think that's certainly the appropriate thing to do. She regained consciousness in less than a minute, but the saddest part is the first thing came out of her mouth was, "Please do not call 911, I could not afford it." Yep. Okay? I think this is the type of life we're living in right now, to understand what that ridiculous cost is when people, in this case, truly would need that service, could not afford that service. So I think this is all part of what we're doing here, highlighting the need of why we are trying to make those changes so that we are not going to be living in that type of a world ever again. That's just inhumane, I would say, at the end of the day. So I just want to say thank you, Nick, for a lot of hard work. Not having folks calling in today may be an indication that a lot of issues have been resolved. I hope they don't save it to Tuesday because that's going to be a very busy board day to ask these questions, and that's why I think the committee is a good place to ask these questions. So by not having any comments, I'm a little bit apprehensive, hoping that is not that case. But in the meantime, between now and Tuesday, I would ask if you could please reach out to the Fire Chief Association and whatnot to make sure that these questions are not necessarily saved till public comment on Tuesday to deal with.
Yeah, absolutely, Chairly. Given yesterday's response, it gives us an opportunity to go back and seek further clarification and actually get language adjustments in the RFP. So we are laser focused on that, sir.
Good, thank you. All right, Chair, Vice Chair, do you have a motion to receive this report, please?
Yes, I will make the motion to receive the report.
Okay, and I'll second that. And without further comments, please take a vote.
Vice Chairperson Abekoga?
Aye.
Chairperson Lee?
Aye as well.
Thank you.
Thank you. All right, it was item 5 technically, and item 6 is the annual report for the EMS relating to the activities and achievements for 25 calendar year. Go ahead, Chief.
Chair Lee, Vice Chair Abekoga, I know we've taken quite a bit of time, so we'll try to keep this brief. But it is a great opportunity to highlight some really great successes outside of all of the work that's been done with the ambulance RFP in 2025. So I think one of the key things, obviously, is having Dr. Darcy come on board, stabilizing the EMS leadership, and really being able to move things forward in a very positive direction. Certainly supporting the transition of regional hospital from HCA to the county and redesignating all of the specialty cares in really short order and in partnership with the Health and Hospital Committee as well as the SCVH leadership to really ensure that that's critical service care delivery not only was reestablished but also compliant with state laws and regulations and our local requirements. Really focusing on the continuum of dispatch to discharge is something that we are always committed to. So converting the Nurse Navigator program from a pilot program to fully a part of our county communications center, as well as then developing a rollout program for that to be the field referral, allowing paramedics to access nurse referral programs countywide was a great success. Additionally, looking at our clinical team, really focusing on supporting folks with breathing challenges. So when someone is unable to breathe, paramedics can insert a tube in their throat, help them breathe. Through our efforts and with our partnership with our providers, increase that from 25% to be, up 25% to now being over 90% success rate the first time they attempt that, which is just a critical skill set that they don't get a lot of practice doing, but it is just so important and vital for patient success. Again, working with our hospital partners, hospital bypass and ambulance patient offload delays actually remained to continue to improve with reductions in both bypass as well as patient offload. And then our community engagement has really sort of skyrocketed. We have a program called Life Files, and those files are essentially for the community to put really critical information about their family and their personal health. We distributed 9,000 life files last year, which is just a significant increase from previous years and really is a valuable tool and value add for our providers as they arrive on scene of these emergencies, help sort of get a level set of the patient's needs. So just in closing here, I just want to thank Health and Hospital Committee, you, Chair Lee, and Vice Chair Abekoga for your support and encouragement as we move forward in the ambulance system, an EMS system, as well as County Executive Williams. Without your support, it really does hinder what we do. So your support enables us to really move forward and engage. So thank you so much for all of your support and open any questions.
Thank you. Any public comments?
There are no requests to speak on item 6.
Okay, Vice Chair, any further comments on this? Okay, good. I just want to say thank you so much for the great overview of what the good work you've been doing for the past year for our 2 million residents of our county. Also want to say thanks and very glad to see the welcoming of our new EMS Medical Director, Dr. Darcy. Welcome. And having really successfully restored our comprehensive care at the Regional Medical Center and expanding the alternative care pathways with the rising demands of our ambulance transports to a tune of 24% since 10 years ago, which is really significant. Couple of questions. Do we have any initial data on the behavioral health assistance transport team that launched early this year? It's an amazing service that can spare our ambulance transports with non-ambulance vehicles.
Thank you, Chair Lee. So that program was a great partnership between our office and the behavioral health team in which, in today's environment, if a patient is placed on a psychiatric hold, typically referred to as a 5150,
Yes.
There are very few options to get that patient from the scene of the emergency to basically either a psych facility or an emergency department. So prior to the behavioral health assessment cars, if there was a scene of a 911 emergency and they were placed on a 5150, that patient was taking a paramedic ambulance out of service to transport them to an emergency department or again, a psychiatric holding facility. The behavioral health assessment transport teams were negotiated as a part of the 9th Amendment, and it essentially is a modified Ford Explorer that's safe for a patient to be put in the back of that ambulance. There are some limits, though, that SUV. There are some limits. They have to be a voluntary hold. So some folks are placed on an involuntary hold. Some folks are voluntarily asking to be placed on a hold. So this is a voluntary hold, and they. Thank you. So voluntarily going into the vehicle, thank you, meaning no restraints.
Right.
And then from there, they're placed in the back and then transported. So phenomenal service. It's new. So we have only had about 30 transports in that vehicle since March. But it is growing sort of month after month and continue to find opportunities to expand that service.
Great, thank you. And regarding the EMS scene time of the 17 minutes with a benchmark of being 15 minutes on the EMS median scene time score, any ideas how we could improve that in the short term?
Yes, so we always talk about scene times for especially our specialty care patients who really need to get to definitive care. And trauma is really one of the most dynamic and really the widest spectrum of patients. These are patients that often need extrication from vehicles. They're on the side of the road. You need to make that safe for the responders and for the patient as they come out. This could be the scene of a shooting. There may be a lot of scene safety concerns. And so a lot of this is around cross-training with other agencies to make the scene safe, to expedite that delay to extrication or even the extrication process. So a lot of that is around cross-disciplinary training and really, communication. Another big part of this is what is happening on the scene during those 15, 17 minutes. It's those life-saving interventions. Those are the time-critical life-saving interventions that would be tourniquet placement for hemorrhage control. When someone is bleeding out, you don't want to just pick them up and move them. You want to get the tourniquet on first, stop the bleeding, and then move them. Or they can't breathe, they're about to code, they're about to lose their cardiac movement. They need to have needle decompression. They need to have a needle put in both sides of their chest by the paramedic. Could be things like splinting or immobilization. You see people with those collars around their necks, and that's meant to prevent them from movement that could make them paralyzed if they move in the wrong way during that extrication process. So I think all of those pieces, you point out trauma because that's really the most dynamic of these, and those are all of the pieces that we get better at by doing those high acuity, low frequency skills training, the cross-agency trainings, and really making sure that we are fluent in those skills in the moment, in the most chaotic of situations. So we do have annual trainings every year that involve these skills. We have reevaluation of our policies that happen once a year just to make sure that we're doing all of the things that we need to do and not doing the things that we don't want to do. So a lot of what I've been able to do over the last 15 months that I've had the honor of being here is looking through all of those and bringing them up to the standards that we want them to be at.
Right. The STEMI patients, door-to-door activation within 90 minutes has a benchmark, I guess, is 100%. 93% is not a bad number. We're doing, that's very close. But what do you think, anything that we need to do to improve that?
Yeah, I think that's a perfect one to look at for our collaboration with what we call our cardiac care system. Mm-hmm. Our cardiac care system meets quarterly. This is a meeting that involves all of our interventional cardiologists, our emergency departments, our EMS liaisons from the hospitals, and is run by the EMS agency. And the idea is we go through all of the data from each hospital. So we disaggregate by gender, by ethnicity, by jurisdiction, and by hospital to see where we need to improve. You're seeing an aggregate number, and that's on purpose. But one of the main things that will bring our entire system up is addressing the other issues that are listed out in the annual report, and that's things like APOT, so ambulance patient offload delays, hospital overcrowding, all of that running back to bigger system design questions like resource matching, nurse navigator, all of those other programs to really offload hospitals of the patients that we can serve in other ways. So I think what you'll see is that high volumes and overcrowding create these barriers. You can also see that the difference between patients who are brought by ambulance to an emergency department, they do get expedited care. The difference with walk-ins is these are undifferentiated patients. And EMS does bring that value to hospitals. And so making sure that all of those services are really outlined regardless of the pathway in which they arrive. And the final part that I think is perhaps the most powerful one that our collaboration with the hospitals can bring us is community outreach. We talk a lot about the stroke symptoms. Everyone knows if they're bleeding out that they should probably get some help for that. But chest pain can often be under-recognized, and especially in older women, non-white women, these symptoms can present differently. And in women compared to men, these symptoms are very different. Chest pain, that crushing chest pain, is not a classic symptom necessarily for those other groups. And so reaching what we call atypical signs would be more important. And that's all part of community outreach. And I think that is one big piece that as we bring together the cardiac care system, that is a huge piece of what we can bring to our entire community for the whole county.
Good, thank you, Dr. Darcy. I don't see any further questions from my vice chair. Do you have a motion to receive the report?
Motion to receive the report.
And I'll go second that. Let's go take the vote.
Vice Chairperson Abe-Koga?
Aye.
Chairperson Lee?
Aye as well.
Thank you.
Thank you very much. Next is receiving a report regarding the SCVH De Anza Mobile Medical Unit Pilot Program. And I believe we have our CEO.
Thank you, Chair Lee,
Paul Lawrence.
Supervisor Abe-Koga. Joining me is Celine Ho, our Primary Care Operations Director. We're happy to take any questions on this item, Supervisor.
Thank you. Do we have any public comment on this item?
Confirming no request to speak on item number 7.
Okay, great. We'll close public comment then. Thank you so much. We were able to look at the report. Very excited at the opening of the mobile unit. And I'm really grateful to you, Paul, and your entire staff, Celine and everyone, for making this happen and happen so quickly. It's exciting to see. I do see that at the same time we have a lot of work to do to get utilization up. I recognize that we opened it, I think, just as summer break was happening, so not a lot happening on the campuses there. My hope is that as we get into, I think school starts in September, we will see more utilization. But that was really my question, was what are our plans to market it more and try to get the numbers up?
Yeah, we are looking to do some increased outreach efforts as the students are coming back to campus. We're looking to do more of those back-to-school events on campus, on the campus sites. We did notice during the summer months, too, that there was a lot of sports physicals happening. And so we'll be reaching out to the De Anza trainers to let them know that they can have the sports physicals on our MMU. And also during this time, too, we made some adjustments to the schedules, whereas initially we had it as all walk-ins. And so we opened it up to our Valley Connection call center. So now they're scheduling in those appointments. And in fact, they're there today, and we're already starting to see an increase in the scheduled appointments.
Oh, great. What kind of inquiries have you had so far, or what are the common
inquiries?
So
they did come. We have out of the small group of folks that we're seeing, they did come in for just the, like I mentioned, the sports physical. There's just a sick appointment that they came in for. And so we did get some folks that just came up to the van to inquire what the services are, but they didn't engage at that time. So we're hoping to draw some additional folks as we let them know of the services that are available to them.
Great. And then how are we looking to incorporate the utilization trends and demographics of the patients in our long-term planning? We hope for expansion.
Yes, we are kind of tracking the demographics of the folks that are coming into that area. We are seeing about half of them that are coming are from Mountain View, Sunnyvale, Cupertino.
Oh, really?
There's a couple that are in San Jose that also were in the area. And so we're looking to make sure that folks know of the services, not just at De Anza, but also the nearby health centers at Sunnyvale and in North County as well.
Are you seeing, in terms of ages, I know it's on a campus, but folks from the community, seniors?
Yes, we did. We actually, the majority of them are the 18 to 54, but we did see 3 that are seniors that are in that area. And as you know, there's a senior
Yes.
housing across the street. And so we did have a couple folks come and inquire about the services.
Oh, great. And then there's a senior center across
Yes.
the way too. So
Yes.
we've been working with them to publicize the clinic. I think they do the lunch program there. So it's a venue for us to go out and do outreach, I believe. So great. Well, thank you. I hope that things continue to trend upward, and I really appreciate again the work being done. Thank you. Thank you, Chair.
Thank you, Paul. You have, okay, nothing yet. Yeah, so yeah, it's unfortunate that the data is still very new and there's not enough folks to come in yet. So hopefully next time when we come back, we'll have more data to see how the service has been used. And certainly outreach is big, and well, school will be back soon. So hopefully since at that time, we'll see more usage and how that goes. All right, that's all I have. Did you have a motion to receive report?
Yes, I will make a motion to receive the report. Thank
And
you.
I'll second that.
Vice Chairperson Abekoga?
Aye.
Chairperson Lee?
I as well.
Thank you.
Okay, moving to item 8, which is receiving report from the VHP relating to member access to providers speaking their primary language. Morning.
Good morning. Good morning, and thank you, President Lee and Vice Chair Abekoga. I'll start by giving a
Let me introduce yourself first.
Of course.
Dr. Sanjay.
Of course. My name is Sanjay Bhatt. I'm the Chief Medical Officer at Valley Health Plan.
Great, thank you.
Let me start with a little bit of an overview and a background. Optum was acquired by United Healthcare. As a result, Optum decided to term with Valley Health Plan in November of 2025. At the time of being termed, Valley Health Plan had about 6,000 covered California members and about 2,500 commercial members who were seeing Optum providers. Soon after, Optum also termed with Santa Clara Family Health Plan. Santa Clara Family Health Plan delegated 35,000 Medi-Cal members to Optum. After terming those 35,000 Medi-Cal members, many of those Medi-Cal members were assigned to Valley Health Plan. When it comes to patients, members, when we lose a provider within the network, a lot of that is regulated by block transfer process. There are certain requirements. One of those key requirements is ensuring that members are reassigned to specific providers. Now, within our process, members are given the choice to choose their primary care provider. However, given the time constraints, members have about 10 days to choose a provider. If they do not choose a provider, then they are assigned a provider. And so Valley Health Plan makes sure we review 3 things. We look at the member's provider spoken language, the preferred spoken language, the geographic proximity of the member to the assigned provider, and does there exist a historical relationship between the member and provider? And if we can facilitate that, one of those 3, we will be sure to assign that member to a specific provider. Other things that are very member-focused are continuity of care. So if a member has an existing relationship with a provider, if that provider is willing to accept Valley Health Plan rates, if there are no quality of care issues found with that provider, and if that provider is credentialed with the health plan, we will approve that member to continue to see that provider. The other piece is continuity of treatment. So in no circumstance do we aim to interrupt a member's care. If a member is receiving cancer treatment, we will ensure that that member continues to access that specialist provider to continue to receive chemotherapy. When it comes to the provider side, at the time of term, there were about 700 providers, PCPs and specialist providers with Optum who are part of the Valley Health Plan and Santa Clara Family Health Plan network. We had our contracting team identified many providers with whom we had an existing contract. If we did not have an existing contract, we pursued contracts with all of those providers. There were a fair number of providers who did not want to contract with Valley Health Plan. The last piece I'll just talk about is the importance of our culture and linguistic program, because I believe the complaint was around that. Ensuring that members have cultural linguistic services is sort of key to the health plan itself. We have multiple reports. We have one called the CNL MPAR report that makes sure that our primary care providers, our behavioral health providers, and our high outcome providers, that we have enough of those providers to meet our member needs from a linguistic perspective as well as a geographic perspective. We also do reports to ensure timely access to urgent and routine appointments. We provide telehealth services in multiple languages if required, and we also provide free interpreter services to members who may have a provider if they do not speak the same language. The final thing I'll point out is we have 6 Medi-Cal threshold languages and 3 commercial threshold languages. Again, that report I mentioned earlier ensures that our network aligns directly with those threshold languages to make sure we can meet the members where they are. Happy to take any questions.
Okay, thank you. Any in public like to speak?
I have one request on Zoom.
2 minutes.
We'll offer 2 minutes to Michael Rogers.
Hi, thanks for your time. This is Mike Rogers. I'm chair of the Health Advisory Commission. At our May meeting, we had over 100 attendees, which is by orders of magnitude larger attendance I've had since I've been attending the Health Advisory Commission over the last 7 years. I was not aware at the time of the relationships between United and Optum and PMG and the subsequent ending of contracts after purchases, et cetera. It's clear there were large consequences and interruptions of continuity of care. We had doctors, specialists, PCPs, and many patients who talked about delays in getting things like biopsies on cancer incidents, not being aware of this beforehand, et cetera. Now that we have more of the history here, and I thank Dr. Bach for providing additional details beyond the report, my concern is what can we do to try and keep a lot of these community doctors in the system and provide continuity of care. I mean, statute requires a year. Have we used up part of that year already? If doctors want to take some time to decide, do they do a contract? How do we provide continuity of care? Is a year sufficient? We have a large community of doctors, 700 here, some of which are pre-contracted with Family Health Plan or Valley Health Plan, but the concern is what's the impact on the community, and can we mitigate that? Do we get the different societies involved, et cetera? Is it a communication issues? Were they aware of all these things? Were people aware of the statute required continuity of care when changing health plans, et cetera? Can we mitigate what has been a significant impact to the community of these business entity changes? Thank you for your time and attention.
That concludes public comment.
Thank you. Vice Chair.
Thank you, Chair. Doctor, would you be willing to respond to the public comment?
Of course. Thank you, Ms. Rogers. So yes, continuity of care, there are multiple points there, but continuity of care, the way it is defined, is for a single 1 year. However, as I mentioned, continuity of treatment has no end. So if a member is undergoing care and that 1 year expires, but the member requires ongoing assistance and treatment, we are in the midst of a treatment plan with that provider, that member will and should continue to see that provider. So there is no question about that. In terms of how to meet members where they are, That is, again, very key and crucial to the work we do at Valley Health Plan. So it is about ensuring that if a member requires assistance, we have a member services team that will help connect to primary care providers. We have a case management team that will help connect to specialist providers, and we have a behavioral health team that will connect to behavioral health providers. In those interactions, nurses to members often, if there are extenuating circumstances, additional member needs that require an extension of the continuity of care or continuity of treatment, we will certainly take that into account and often authorize services beyond the 1 year continuity of care requirement.
Thank you so much. Thank you for this presentation, and appreciate it. I remember we had some public commenters at a board meeting, and I think that's what sparked this agenda item. So I appreciate the explanations. Certainly language access is really key in our diverse community to be able to provide equitable care. And as myself being the translator for my parents, my immigrant parents who didn't speak English, and I went to all of their doctor appointments and was a translator, I've seen the challenges of navigating the system when you don't have that language access. So I appreciate that 95% of our members speaking a threshold language have access to our PCPs. I was just wondering, are there specific threshold languages where we anticipate future challenges in maintaining language provider capacity?
It's a great question. That's a great question. Our Medi-Cal line of business has 6 threshold languages: Vietnamese, Spanish, Chinese, Tagalog, Farsi, and Russian. Farsi and Russian are the 2 languages with which we are regularly in search of additional providers for. For a commercial line of business, it's Vietnamese, Spanish, and Chinese.
Okay, great. What are we doing to recruit more of those languages?
It's a again, this is a little bit out of my comfort. It is part of our network contracting team.
Okay.
We do bring, our team will go out regularly, will identify the disparity, will sometimes just do cold calls, do reach outs through additional providers, go and visit provider offices in an effort to encourage them to contract with Valley Health Plan. If a provider does not wish to contract with the health plan, oftentimes they will engage in what's called an LOA. So they will continue to be allowed to see the member at a negotiated rate for a single case or a certain number of visits.
Right. Thank you. Thank you, Chair.
Thanks. As you mentioned, there was about 100 folks who attended the May Health Advisory Commission regarding these, honestly, real big headaches for our patients during, no fault to them, right? That this change took place due to these back-end merger and sales, whatnot. So I think the bottom line, is besides language that's been addressed, is there any way we could help our patients to gain better access, especially to the PCPs that they clearly were happy with? How can we get them connected back if they are not member of VHP?
If they are not, sorry, may I ask just clarification?
You're saying
If
that
they
some
are-
doctors, some physicians, PCPs are not willing to contract with VHP, right? And that's the reason why they can no longer be providing that service to those specific patients. But if these are the same PCPs that the patients clearly have a pre-existing relationship, would like to be connected, what are we doing in terms of options to let them know how else can they potentially get connected to these PCPs? Or it's just not doable?
Well, we are still within the 1 year window. So if a member wishes to continue to see that provider, they can and will be allowed to see that provider under the continuity of care provisions. So they can continue to see them through the extent of a year. After that 1 year, if they are safe to transition and the provider does not want to accept VHP rates, we then connect them to our case management team who understands what the needs of the members are linguistically, LGBTQ+, et cetera, and make sure that we do our best to connect that member to a provider who meets their needs.
I just want to make sure that this is, I mean, you explained to us this is a one-year extension. Does the patient know that? And how we can make sure that they are aware that this actually exists?
I do think we could do a better job. You know, part of the block transfer is that we need to notify members about this change, but also the provisions of continuity of care. So the state puts out a document that's included in the letter that explains the 1-year allowance of continuity of care.
And I would just add, DMHC regulates all of these member communications. So there's very specific language that health plans must provide when there's a network change. It's regulated language that's provided, and it is provided in multiple languages. Some of you may have gotten these in the past yourself. It is regulatory language. So, you know, it talks about the 12-month continuity of care provisions. It talks about how you can contact DMHC if you have a complaint, et cetera. I did just want to say with this whole Optum shift, it wasn't just VHP and SCFHP. Anthem had the same issue. Basically, these situations arise where, because of the fiscal realities of payment, in this case related to Medi-Cal covered California, a provider network may choose to stop providing service to a certain payer mix. And there was clearly a broader set of negotiating things that was going on here with across multiple insurance providers with Optum after the acquisition that really had to do with negotiations and rates. And so, you know, the fact that that was inclusive of really big entities like Anthem and their kind of broader network is a good indication of that. And so while we offer continuity of care, we try to have individual relationships with specific individual physicians. We also have to pay within an appropriate market-based parameter, right? And so not every physician group is going to end up being in network because we're not going to pay the rates of every physician group might demand. So we have to make sure there's adequate network. We do have a network that's beyond the county network, but there is that back and forth that happens between every insurance provider and every healthcare provider.
Doc, is there any data we could find out how many patients were able to retain their PCP and how many were forced, or in this case, are told that they have to change?
Is the request for a specific line of business? Is it for Medi-Cal, commercial, and covered California?
Yeah, I think that from the point of view from the patients, right? They don't really care what program they're on. They're just saying, hey, look, I had this doctor I like. Now you're telling me that I can no longer see this doctor anymore. Is there any way we could get some data to find out how many percentage of, or the number of patients we're talking about that's being affected?
Yes, there is. Part of the reason I asked that question is SCFHP owns half of the data with Medi-Cal, and we own the other. VHP owns the other
Yes.
half.
Mm-hmm.
But yeah, we can work with them, and I can certainly pull that data.
I think it would be instructive for this committee, at least, to understand the extent of how many individual patients are being affected. Then we know how many we need to potentially have to deal with, number one. I think that, to me, is a good start to understand the extent of how extensive this problem is. James, your light's on. Go ahead.
Yeah, well, we're about to see a much more serious disruption occur on January 1, which is over 60,000 folks are going to lose access to managed care altogether and are going to shift to the state fee-for-service Medi-Cal schedule. And I expect many primary care providers to decline to operate under that structure. So they will lose access to their PCPs, and they will show up at our system. So that's a much more serious and significant disruption imposed on us by the governor and legislature who decided to shift the entire state-only population out of managed care. Many of those folks may stop accessing primary care altogether. So I name that because here we're talking about 6,000. January 1, we're talking about 60,000 who will have a really serious disruption in their whole relationship with healthcare. And I think that's just the tip of the iceberg, because the reality that's happening with healthcare in California, absent some stabilization, is that network shifts are occurring significantly and coverage losses are stacking up. I think we're going to continue to see covered California enrollment decline. And I think we're going to continue to see some really significant provider disruptions. So, you know, we are doing what we can in that space, but we're talking about very, very large sums of money that are at stake in terms of federal and state resources that have a big implication for what healthcare looks like and what that means for access. So.
Okay, thank you, James. So first, thanks for that heads up of this change on January 1st. Second is, Dr. Sanjay, how long do you think it will take to pull these data? You think they come back to us in a couple of months?
I do.
Okay, so we are August right now. Say by October, HXC meeting, if you could send get those out to us, just to have a good grasp of how many patients is being affected in terms of having to change their primary care physicians. And of course, it might be also good to know that how many were able to retain the PCP because the PCPs were able to stay on VHP, right? I think that contrast will be good to know before we have to deal with the January 1st issue, which is a much bigger issue, of course.
Yes, happy to do so.
Right, all right. If that's the case, I would like to ask to make a motion to incorporate those comments as being made and the deadline of coming back to us in October Health Hospital Committee on those data, if that's okay to my
So
Vice Chair.
moved.
Okay, moved and seconded. All right. Thank
Vice
you.
Chairperson Abe-Koga?
Aye.
Chairperson Lee?
I as well.
Thank you.
Thank you. All right. Then next we got item 9, which is the recommendations from the County of Santa Clara Health System relating to current and emerging healthcare issues.
Thank you, Chair Lee. Let me just start by stating, of course, you have our operational report, but I do want to take a moment to highlight a couple things and just to remind everyone that your healthcare system is under significant financial pressures, obviously due to H.R. 1 and more recently the state budget. James Williams just discussed and described the impact relative to the UIS population. In 25-26, we came to your board with $200 million in budget initiatives. I'm pleased to say that we've closed a year on budget. We just recently closed our books, and you know that's some good news. But we have in front of us, as I've mentioned, some significant challenges. In the adopted 26-27 budget, we have about $200 million in budget initiatives that we have to deliver on and perform on. And that has to do with revenue improvement, but also operational efficiencies and some other operational efforts. The outlook for 27-28, and this is something that James Williams has also conveyed to the board and to the community, is that we have the major provisions of H.R. 1 taking effect. And as a healthcare system already, we're projecting about a $300 million shortfall. That is absent any additional support from the state. And as you well know, the IGR team is working really hard with your offices and our state delegation to see how we can actually get some longer term fixes in place to address HR1, but also some of the deficiencies that we're seeing from a budget standpoint coming from the state level. I share that with you because I think it's really important for people to understand that we're still in the midst of this financial challenge as a healthcare system. And on top of it, we are already experiencing increased demand on your system. The numbers that I reported yesterday to FGOC about RMC clearly reflect that, but we're seeing that across the board in the healthcare system. And on top of it, we're already seeing some of the expected changes, disruption in the market. The last 4 months, the reported number of Medi-Cal enrollees has started to decline, about 1.5% each month. That equates to 4,000 to 5,000 enrollees, Medi-Cal enrollees per month. So think about that. Just in a very short period of time, 20,000, 25,000 individuals are no longer enrolled in Medi-Cal. And we have yet to hit January 1 when the major provisions start to be enacted. So I just want to kind of make sure that everyone understands that we're in the midst of some significant challenges and headwinds. It's not to say that we're not making progress as a health system, because we are, but when you take a few steps forward, obviously we're being pushed back several steps relative to our financial situation. So I just wanted to convey that again to this committee and during this meeting. And I'm not sure if James has anything more to add to that.
Yeah, I would just say that we're about to see the real significant impacts coming January on enrollment. And then the fallout from that will take, of course, several months thereafter. So, we will monitor what's happening, but the fiscal consequences, but much more importantly, the human consequences of loss of access to coverage are going to be felt very deeply in the community. So we will obviously keep the board continuously updated about all of those pieces, but it is already starting, and there's a big acceleration that happens January 1. The state, by the way, is not making things better. It's making things worse. And we certainly look to a new gubernatorial administration to maybe take a different perspective around that come this next budget cycle.
Okay, thank you, James. Yes, actually, do we have any public like to speak on this item?
There are no requests to speak on item number 9.
Okay, Vice Chair, you have anything to add? Okay, good, thank you. So I just want to say there's a couple of really good news here to say congratulations, Paul. First is actually I do have a question is, what were your initial first year projections for the Compass Clinic patient intake?
Well, what I can tell you, I don't recall the actual expected projections or numbers, but we clearly far exceeded our expectations. In the first year, 500 patients have been served, over 2,000 visits since opening. I can tell you that the low barrier access and strong coordination with the public health department and the behavioral health department really has made the Compass Clinic a regional model for addiction treatment. It really has. And coupled with the Compass Clinic, we started the inpatient consult service for addiction medicine. And what we do know today, and this is really impressive, is that an individual that has received care on the inpatient service and received that consult support are 3 times more likely to follow up in our outpatient care setting, which is really important because that continuum of care and support is critical for their recovery and support. So the program has really been remarkable, and we're very pleased.
And I would just say thank you for this great update, because certainly these are incredible numbers of providing a new way of providing, basically, I'll call it the same day access to substance abuse, substance treatment services, which is something that is truly revolutionary, and it's not easy to do. And I just want to say thank you for this amazing leadership and support to make this happen. And these numbers speak volumes of how important this work is for our community. So I just say thank you for that. Second thing is that we, the third year in a row now, our VMC Rehabilitation Center has been ranked number 8 nationally, which is really the #1 center for rehab in California and the entire West Coast. So this is a real big deal. And you know, there are also other specialties also recognized as high performing in the national metrics, more like highlight, which includes colon cancer surgery, heart failure, maternity, pacemaker implementation, pneumonia, and stroke care as well. So I just want to highlight these good news, because we always hear bad news in the news, but I want to make sure that good work is being recognized. Just want to say congratulations. Thank you for the good work, and keep it up.
Thank you, Supervisor.
Okay, next we get the report from our Public Health Officer, Dr. Lim.
Thank you, Chair Lee. I just have 2 sort of late-breaking items to make sure I am sharing with this body. The first dovetails really nicely, actually, with some of what we were just hearing about both our clients in Valley Health Plan and patients served by SCVH, some of the work of our Asian Pacific Islander Community Health Worker Network and some of the major achievements since the last time I reported out to this body focus specifically on making sure our population who is eligible to stay insured stays insured. So one of the, I mean, they sent me such a long list of achievements, I won't read them all out to you right now, but I will offer my congratulations to our partners at ACI and all of the groups doing this amazing work. But they did receive a funding from Santa Clara Family Health Plan to do extensive outreach on helping people understand their rights as HR 1 went into effect, especially as it relates to documentation status, or what we call unsatisfactory immigration status. And they conducted workshops on Know Your Rights, reaching over 800 residents. They had 25 outreach events, reached over 12,000 residents through these. And their entire network will actually be featured by the California Healthcare Foundation to share some of their impressive achievements, especially in partnering with Lead Filipino, CACS, and Vivo. And then I actually had the honor of attending the first graduation ceremony for the CHW certification and training process, specifically in Vietnamese and for our Vietnamese community members. And it was incredible to hear the stories, especially of folks who have often devoted their entire adult lives to the health of their community, but in an unstructured, unsupported way, now having a system not only to bill for and support their work, but to make sure they get all of the emerging information they need to bring it to their communities. And so, again, much more I could share. We'll be happy to bring that in writing next time around. The only other issue I want to just touch on has to do with the fact that we are in back-to-school season. In fact, I dropped my own second grader on her first school bus ride to school today, which is a reminder about that quickly after our little ones start exchanging germs, once they're back in school together, it's a perfect time to make sure everyone's up to date on their recommended vaccines, which is, again, just another part of growing up and making sure our kids stay healthy so they can do the more important things like argue about which seat on the school bus they're going to take. And so public health has been pushing out some messages to help make sure people understand, for example, that this latest federal executive order related to vaccines actually has no change on what is recommended, required, or accessible here in California. It proposes some changes that I think even folks who have concerns and questions about vaccination often don't ask for, don't want, things like splitting up the already required vaccines into more shots. And so we're doing a push to make sure people understand this does not change anything for us here in California. We're still a community that cares for ourselves and each other by staying up to date with these recommendations. But I will note that we are already seeing a rise in COVID in the wastewater, looking similar to how things looked last year in August, when we then saw quite a high level. And if you remember September the way I did, it felt like if you didn't have COVID, you knew someone who did. It was sort of that type of fall. So we may be headed in that direction again, which is a good reminder for anyone, especially who is over 65 or has any medical condition that puts them with a weakened immune system, that they can actually get a second shot of last year's COVID booster 6 months after their last one. So if it's been 6 months and you're in one of those vulnerable groups, we do recommend an updated COVID vaccine while we wait for this next winter's vaccine to become available for us.
Is that covered in terms of cost?
It is. So because of the changes California made as federal vaccine policies started to change, there is still a requirement that these vaccines be available here in California, that the same accessibility and things like pharmacists being able to administer them is still unchanged, that insurances are still required to cover them when they are recommended by the state health department, as this one is, and that there are still protections for doctors, nurses, to continue to do the right thing and make sure their patients have access to the vaccines they request.
Got it. Thank you. Yes, I cannot imagine anyone would want to do 3 shots of the mumps, measles, and rubella versus 1 shot. I think if you poll 100% of the kids, 100% will say 1 shot's more than enough. I don't want 3. So there we go. And the good news is there really is no change to how we administer right now that we know of. Right?
That's exactly right.
Great. Thank you. All right. Any further questions? No? All right. Thank you, Dr. Reitman. And next is our Deputy Director, Behavioral Health Service Department, Megan Whelan. Hi.
Thank you, Chair Lee, for the intro. Good afternoon. Is that close enough to catch my voice?
A little
It
bit
is.
closer.
Okay.
Yeah.
First time.
There we go. Yep, that's better.
All right. Good afternoon, all. This has been a very busy summer, you can imagine, for BHSD. It's been full of transitions, goodbyes, new beginnings, and intensive monitoring of the clients in our care who are experiencing transitions. You have our written report detailing the efforts made specifically for the 40 youth who are receiving treatment through the CFCS Alexian Clinic. At the time of closure, they were assessed, connected to care, and transitioned, receiving services all through the summer. In addition to the closure of CFCS Alexian, BHSD staff worked tirelessly over the summer to transition clients from all 6 clinics and programs closed as a result of the FY27 budget process. These clients were assessed for ongoing treatment needs, connected to a new provider as needed. This included the transition of 1,020 clients who were connected either to other county clinics, CCP clinics, providers through the managed care plan, or no longer needing services. We currently have a transition team that continues to track all of the clients' transitions to ensure that every client referred to a contracted provider or our county clinics gets connected. To date, there are only 51 clients who are still in the process of getting connected to care, and our transition team continues to follow up with those clients to make sure they are ultimately connected to the care they need. That team of 7 staff will be active until the last client is successfully transitioned. And then the staff retained from the closing clinics have transitioned to their new clinic sites, bringing additional capacity to those remaining clinics so that we can strengthen those remaining clinics and improve their ability to be financially sustainable and provide care to the community over the long term. This is really just one piece of our overall strategy to improve the financial sustainability of our programs and maintain a robust network of services in the face of HR1 and other fiscal challenges.
Thank you.
That's my update.
Nope, nothing else? Okay. All right. Moving next to CMO of Valley Health Plan, Dr. Sundrigan. No?
Thank you. You know, the 2 things I'd like to point out on the report, and we talked a little bit about this initially, is the significant downtrend in our membership. I think as Mr. Lorenz just pointed out, since January of 2026, we've seen about an 11,000 drop in lives in membership, about 6%, and we're only halfway through the year. We've seen a steeper drop in our covered California line of business, almost 30,000. So we went from about 25,000 members to about 17,000 members, and we expect to continue to see drops in the membership there. We've also recognized that our PCAP enrollment has now doubled to almost 3,700 members since last fall. I do want to highlight a second item which we should all be very proud of. Our quality scores are measured by HEDIS, the Healthcare Effectiveness Data and Information Set. For all three lines of business, for our Medi-Cal, Covered California, and commercial lines of business, we have seen year-over-year improvements in our HEDIS scores. In fact, in our Medi-Cal line of business, 7 of those scores are above the 90th percentile, and 3 of them are above the 75th percentile. We do put a significant amount of emphasis on our blood pressure control metric, which is a metric that we did see a small decline in all 3 lines of business. Special appreciation to our providers, SCVH, and our membership, as well as the VHP staff, to see year-over-year improvements in those scores. Any questions?
Thank you. We don't have any further questions. Thank you. And then next we have the federal and state health policy and budget landscape update from Angie Melton.
Hi, everyone. Thanks for having me. Angie Melton with McAllister and Quinn in DC. I'm here on behalf of Bert Margolin, who cannot be here today. We work together on the federal issues for Santa Clara. I'm going to be very brief because I know we've had a lot of great content already today. Just wanted to cover a couple of quick things. How the Congress is currently on their August recess. I think it would be lovely if the House and Senate took their breaks at exactly the same time like the California Assembly and Senate do, but that's not what they do. So the House will come back on August 31st. Then they'll be out again the week of Labor Day, and the Senate is out until September 14th. Then they're both back in session for a very brief 3-week period before they recess for the election. So not a lot of legislating time between now and the election. Just before they recessed, they did pass continuing resolution. Both the House and Senate passed slightly different continuing resolutions, which would forestall a government shutdown. The Senate's version is a little bit different, and the House Republican leadership has said that they will take that up as soon as they return the beginning of September, and they expect to pass it. So it does seem like they're trying very hard to at least put off a government shutdown until December at a minimum. So they're going to have a continuing resolution that would extend government funding from the fiscal year 2026 levels through December 11th. And it also has a couple of anomalies requested by the White House. One other provision is that the Senate added, and it seems like the House is going to be okay with, is a delay of implementation of changes to the uniform guidance for grant recipients. The Office of Management and Budget had put these proposed these changes. They got a lot of comments. It basically politicizes the grant making process somewhat, not even somewhat, but there was a lot of outcry. They got almost 500,000 comments. So the Senate has put a provision in to delay implementation of that. Doesn't seem that OMB would actually have been able to process all the comments before December 11th anyway. So that is one provision that's different from the Senate and House. So we expect that to happen. So no government shutdown in October. We will see what happens after the election. The other thing I wanted to mention is the other piece that I know everybody's really interested in is budget reconciliation. HR 1 was passed through the reconciliation process. There's been already one reconciliation bill passed this year that was very, very narrow, funding ICE and CBP. They now have been working on a budget resolution that would again be narrow, relatively narrow. It would be funding defense, some intelligence issues related to the war in Iran, agriculture, some extra payments for farmers, and provisions that they say will be able to implement the Save America Act. It's through grant funding, so it's a little bit unclear that will actually make it through the Senate reconciliation process, but that is their intention right now. The good news about that is that it does not include any provisions, any instructions to committees related to healthcare. So at this time, there's no option for them to have additional cuts on the healthcare side in Medicaid or Medicare. I know there've been a lot of conversations about waste, fraud, and abuse, and they wanted to potentially include that in a reconciliation bill. So far, it does not seem like they would be able to do that with the way they've shaped the budget resolution right now. Now, the budget resolution has not been adopted by the Senate. It would have to be adopted by the Senate and then taken up again by the House for it to go through. And they haven't done that yet. That may wait until the lame duck session of Congress after the election. And the last thing I'll just mention is that lame duck session of Congress that happens every 2 years after the election, starts the week after the election and ends usually the week before Christmas with a week-long break for Thanksgiving. It's a very short session and they end up cramming a lot of stuff in there. Just a note that it is very much affected by what happens in the election, depending on which party controls the houses of Congress. For the next Congress will determine how willing they are to work together to get things done in the lame duck session of Congress, and how willing the president is to work with the minority party. And so, you know, I'm happy to take questions about any of these things. I wanted to keep it short, but I'd be happy to expand on anything I mentioned.
Okay, thank you so much. I don't see any questions further, but any comments from public? Oh, we already checked. There isn't any. Thank you. All right, I think that's all we have on this one. And I believe that comes to the end of our agenda today as well. All right, so this brings us to the end. And oh, yes, that's right. We do want to take a moment to welcome our new County Council representative, Michaela Lewis, for replacing our long-term County Council representative, Doug Press. This brings us to the end of the meeting, and we will be able to adjourn now until the next meeting being scheduled for Wednesday, September 16th, 2 p.m. Right here, same time, same place, but not different time, 2 p.m. Thank you. Meeting adjourned.